Okay, we're going to get started. I am very happy to welcome all of you to our 15th annual Eyes on a Cure Patient and Caregiver Symposium. Yeah, it is so great to look out and see so many familiar faces and new faces. And we just want to thank you for making the trip here and for showing up and meeting one another. So we have a few announcements. We have a quick welcome presentation, but I'm Miriam Kadosh. If we haven't met, would love to meet everyone individually. I direct the education program at the Melanoma Research Foundation alongside my colleague Caroline. I'll let her introduce herself.
Hi, everyone. My name is Caroline Glavin. I am the Education Program Manager at the MRF, and I work with our rare melanoma subtypes, including ocular melanoma. So it's so great to be here with all of you.
So a few announcements before we get started. There are bathrooms through the breezeway to the right. I had a million announcements. Okay. On the tables here, there are little microphones. We don't need to use them today, but do please be careful with drinks because sometimes it can get sticky on the table and the microphones get a little stuck. So please be careful. But if there's a spill, just let us know immediately. Um, we also want to acknowledge if anything becomes too much for anyone in this room, please feel free to take a break, take a step outside. There's a lovely courtyard and patio if you'd like to take a walk. It should be hot today, so keep that in mind. But please do take care of yourself. We will note in the program booklet that everyone has that there are opportunities for alternative sessions. So you could step away and meet with our social workers. Both Caroline and I are also social workers. So feel free to grab us, take us out, and chat with us if you'd like. And we'll get started with the presentation.
Yeah.
First, we'd like to thank our industry sponsors for being here today and for providing us support for this event. If you are industry in the room, can you just raise your hand so that patients can know who you are and say hello? Thank you for joining us. Thank you to Aura, IDEA Biosciences, Castle Biosciences, Delcath, and Immunocore. We also want to say a special thank you to the Miller and Zubek families and friends. They made a gift for our scholarship participants this weekend, so thank you to them who were able to provide scholarships for travel and lodging for some of us who are here today. So thank you to them and their kindness.
And then this is also in your booklets as well, but this is just the schedule for the weekend, just to kind of take a look up at the screen, get a gist of it. And again, helpful tips. If anything feels like a little bit too much, please feel free to step outside and also get a chance to connect with each other this weekend. I know we had our welcome dinner. Thanks. Thanks. We had our welcome dinner last night, which was an incredible event and lots of fun discussions, laughter, and joy. So continue that this weekend and connect with each other. Feel free to share your phone numbers, your emails, whatever feels comfortable to you. And also, we do have Hazel here today and her team doing photos as well as testimonials. So if you would like to do a testimonial, feel free to grab Hazel. Hazel, could you raise your hand? We've got Hazel and then Hazel's teammate over here. So please feel free to grab them if you're interested in doing a testimonial. And yeah, we're just really excited to have you all here. Yes, and we will also have snacks during the breaks. So you will be well fed during this weekend. And if you're not, let us know. All righty. Okay, and then just to kind of give a little bit of a background of the MRF was founded in 1996 by Diana Ashby. Diana was a melanoma patient who died after a 3-year battle, as there were no options or new therapies or clinical trials for her. And because of that, she started this foundation in hopes to create more space to find more cures in research, advocacy, and education. And this picture here, as you see, is Diana and her husband, Captain Jeff Ashby.
Yeah, so over time, this is actually our 30th year of the foundation. So over time, the mission has changed. So our mission statement now is to eradicate melanoma by accelerating medical research while educating and advocating for the melanoma community. And we'll talk about what that means, but we're here at an education event. But CureOM, which is underneath the umbrella of the Melanoma Research Foundation, is our program to support our ocular melanoma community. So CureOM actually stands for the Community United for Research, Education, and Education of Ocular Melanoma. So we were founded in 2011 by a patient and his caregiver, Sarah Seelig, and her husband, Greg. And many of you have met Sarah, who is a wonderful pillar who co-founded the foundation. And so we're so grateful to her who, similar to Diana, said, there aren't enough options for patients. And so let's change that. And that's what we've been doing since 2011. Our footprint today is rather wide. We're a national foundation. You may see yourself up here, but we go to Capitol Hill. Oh, this was the baseball game last year in Cleveland. And have multiple events throughout the country. So we'd love to come to you and see you in your home city as well.
So as Mary mentioned, we have those three pillars of research, education, and advocacy. So research is really at the heart of our mission. The MRF works to support scientists who discover whose discoveries lead to better treatments, improved outcomes, and new hope for melanoma patients. This slide kind of highlights some of the groundbreaking research the MRF has funded in the past and continues to fund today. And if you want to learn more, all of this is on our website at melanoma.org, but you can also scan this QR code if interested to learn a little bit more about that. And then, so since 2011, the MRF has provided over $450,000 in funding through 6 grants to support melanoma research at the University of Miami. So through these grants, researchers have produced exciting results for the melanoma research community, including 12 scientific publications and a new patient patent for compositions and methods for determining the risks for cancer metastasis. And in addition to that, Dr. J. William Harbour started an investigator-initiated clinical trial sponsored by Bristol Myers Squibb to evaluate PD-1 and LAG3 directed checkpoint inhibitors, immunotherapy in patients with metastatic uveal melanoma. So the MRF funded that research that Dr. Harbour worked to help create, and eventually we were able to have a position to make that into a clinical trial. And although the MRF didn't directly support that, we did support that research with Dr. Harbour. So excited to report out on that. And then also, this is just a little bit more of a continuation of the work that we've been doing in the research space. So research grants, we've awarded over $2.5 million for 28 grants focused on OM, so in the CureOM space. And then we also host a global OM meeting each year. This happened last 2015, this past year in Amsterdam. And we do have a report out on that of our team that joined the event. So if you want to hear a little bit more about that, we have the blog post up on our website, and then a published report is coming out soon. And then we also have our vision registry, which we'll touch on a little bit later in the slides.
Yeah, so our global science meeting is actually for researchers and scientists to come together. So we have that once a year, and then we have this patient meeting once a year. So I just want to do a grant spotlight on one of our grants that we were able to provide. So this was called the CureOM Options Bring Hope Team Award in honor of Lindsay Zubak. You may know the Zubak family. As I said, they sponsored the scholarships this weekend. And this team award was led by Bruce Cassander at the Eye Institute and in collaboration with Dr. Hawk at the Dana-Farber Cancer Institute. And they looked at why do uveal melanomas leave the eye and form metastatic tumors in the liver of patients and not in other organs, which I think obviously is a very important question in this space. So I already heard people asking that question last night. Um, and I just want to take a moment that we are deeply saddened by the passing of Lindsay over this past year, and really thank her family for continuing to pay powerful tribute to her and honor her. And we'll spend some more time talking tomorrow about her as well.
And these are just a slide to highlight a little bit more of what we're doing in our education space, specifically patient education and support. If you see outside, we have a little table out there with a lot of our educational materials, including our newest Ocular Melanoma Patient and Caregiver Guide, which we took a long time going through and updating and worked really closely with experts in the field to create that. So we're really happy with how that came out, and I think will be a wonderful resource for this community. So feel free to grab a copy on your way out. We also have it as a PDF that's downloadable on our website. So you're welcome to get it there if you want. If you're a provider, if you know of providers in your area that might want multiple copies, let us know and we can send it to them. We have it for order for free. In addition to that, we also host webinars. Maybe some of you have been to our Ask the Expert webinars that we host. We host a lot of them monthly. We have these educational meetings throughout the year. We have an animated patient video specifically to metastatic uveal melanoma, and that was just published. So feel free to look at that on our website. And then we also do host 2 virtual support groups. So we have one the first Wednesday of every month, and that is typically for metastatic patients, but it is welcome to all. And then our second one is the 4th Thursday of every month. And I host that one. It's in the evening time. It's 7 to 8 p.m. Eastern Standard Time. And both of those are on Zoom. So we would love to have you join us if you'd like. And then the MRF is really, really proud of this resource that we offer. It is a clinical trials finder. And what's really wonderful about this resource is you get partnered up with a navigator. So somebody to kind of talk through the different trials that might be available to you. I know there are a lot out there and it's hard to navigate that space. So this is a resource in which you can get partnered up with somebody who can kind of walk you through those steps and answer questions.
So all of our videos that Caroline talked about are on our website and on our YouTube channel. We're being recorded right now. So just so you know, all of the sessions this weekend are recorded so you can go back and watch them. We will not be recording the support groups or the psychosocial session later this afternoon, but all of the educational sessions will be recorded. You can send them to other people as well. And for those people that couldn't join us in person, they'll be able to watch them as well. Caroline talked about our Ask the Expert. Next, I'll talk about advocacy. Has anybody here been with us on Capitol Hill to our Hill Day? All right, we're going to change that for next year. Every year we go to Capitol Hill with our patient advocates and they talk to their state legislation and policymakers, and they talk about the importance of research funding and making sure that that does not get cut, amongst other key issues of the year. But we bring members of our community to Capitol Hill. They can meet one another and go to their state representatives. So really great opportunity if that's something you're interested in, and we can definitely share more about that. Next, I wanted to share, we have our Miles for Melanoma 5K walk or run. And these are the upcoming dates. So if we're going to be in your city, we hope that you'll join us. But we have about 17 miles for melanoma across the country. And these are community events, fundraising events, and a really great way to come and create a team and support melanoma research.
And then in addition to some of those different opportunities that we talked about, our Miles for Melanoma, our educational opportunities, we have many prevention and awareness campaigns. As you see here, we have one specifically for mucosal melanoma, which is our Out of the Shadows. We have pediatric, we have our new ACRO one, which is hashtag hands, feet, nails. And then for this community, we have our hashtag I Get Dilated campaign, which typically happens in the month of November. And it's an opportunity to share the importance of a dilated eye exam in this community. And we want to also open it up to the group here that if you would ever want to share your story or partake in our hashtag I Get Dilated campaign, we'd love to have you. You can always tag us with that hashtag, or you can reach out to us if you'd ever want to share a testimonial or story. We would love to have that. And in addition to that, these are more ways that you could support the work that we're doing in the ocular melanoma space. So as I mentioned, we have that hashtag I Get Dilated each November. And then in addition to that, we have awareness campaigns and just opportunities to highlight the voices of this community. And we like to do that throughout the year. So would love to hear your testimonials and the ones that we're doing today. We like to feature those throughout the year. We will be kind of doing a wrap-up video for this event. And then there's also opportunities to participate in ocular melanoma research. This one is pretty important, and we're kind of still building it up. But if you are a metastatic uveal melanoma patient, we want to hear about your experience with coordinated care, surveillance, financial impact, and more. So if that sounds like you, or you would be interested in sharing your story, please do reach out to us at cureom@melanoma.org. And then there's other opportunities. We have a quarterly newsletter for our OM community. It's called Eye on OM, and you can sign up for that on our website. And we give updates in the research, what we're doing with education, patient support, and just different ways to get involved. We also have our patient forum that asks the experts, and as Miriam mentioned, our Hill Day each year. So lots of opportunities and ways to get involved, and we would love to, continue to see you all and engage. So if that feels of interest to you, please feel free to reach out. And then, as I mentioned, this is just more information about those two support groups that I talked about. So that first Wednesday of the month from 1 to 2 p.m. and that's Eastern Standard Time. And both of these are on Zoom. So feel free to join us from wherever you are. All right.
I just want to make a note that in the back of your program booklet, there is a notes section. So if you're looking of where you'd like to take notes today, you could do that there. I also want to talk about our vision registry. So our vision registry, if you may not know, is a patient-powered registry where we ask patients to fill in their information for research. The registry is currently on an administrative hold while we transition over to Georgetown University. So we're going to be led by a primary investigator, Suthi Rapaswan. So Dr. Rapaswan is both a clinician researcher in the uveal melanoma space and has been on the cutting edge of adjuvant OM clinical trials, which we'll hear about today. But the move to the platform will allow the MRF to engage with the biostatisticians there to better analyze the data so that we can benefit more patients. So hold on with registering, but we will be open at late spring 2026, so very shortly. And we'll be rolling out an app to make it a little bit more easy. There will be a bunch of surveys in there for patients to fill out about their journey with OM. Caroline did mention our Eye on OM newsletter. I know we're giving you a lot of information, but we're here all weekend. So if you have any questions, come to us. There are ways to get involved and support the work that we do through our community fundraisers, our galas. We have two, one in Denver, one in New York. I know there's some folks in here who have gone to those. Thank you. And then our Miles for Melanoma, which we talked about. We also want you to share your symposium moments, which also someone earlier said that they didn't know what a symposium meant, which was good feedback. But this is what we're doing here today. So please do share your symposium moments. If you'd like to tag us on social media, we're at, which are the next slide, at MRF Cure OM, at Cure Melanoma. These are the different social pages. And also, Something else I've been talking about with some of you is how we get the word out about these type of events. Obviously, we have social media, we have our newsletter, we have email, we have lots of different ways, and we communicate with your care teams. But if you would like to help us in those efforts, some patients suggested maybe bringing flyers to their doctor's offices or supporting us in other ways to get the word out, because we'd love for patients to know about these great resources and know that there's a community out there for them. So we're always trying, and those efforts are going strong, but we'd love your input. And that is all we have. We want to thank you all for being here. We want to thank our sponsors, and we really want to thank the U Miami, Sylvester, and Bascom Palmer teams for working in partnership and collaboration with us. We could not do it without them and their beautiful space and for hosting us. So that being said, I'll turn it over to Dr. Williams. Thank you.
Well, good morning. Thank you all for being here. Really excited to see your wonderful faces. I got to hang out with many of you last night at dinner, and it was a lively and spirited conversation. I very much enjoyed it. So I'm Basil Williams. As I explained to special to us, Ed, last night, it's pronounced like razzle dazzle. So that makes it easier if you're having trouble pronouncing it. So I am happy to be part of the ocular oncology service here at the Bascom Palmer Eye Institute at University of Miami. And we're really excited to be partnering with the Melanoma Research Foundation in their efforts. I mean, that was such a wonderful presentation about all of the things that they do for patients and honestly for us too, because these resources really help us in our understanding of what you're going through and help us to provide better resources. And so I really want to thank them for all of their efforts for putting this on. I was fortunate enough to participate in the meeting in Tampa a few years ago, and it was a fantastic event. It was actually the first time that I had been to an event specifically for patients, and it really changed my perspective. At that time, I had not had any medical problems of my own, and so I didn't really have any insight or understanding onto the other side. Since then, I have been perhaps less lucky, nothing serious, but I have started to understand it a little bit more. You know, you hit post 40 and your body starts hurting for no reason. And so I have more of an appreciation. So I just want to give a little bit of background about our side of the partnership. So University of Miami is really, really happy to host you here. So this is a joint effort with the Bascom Palmer Eye Institute and the Sylvester Comprehensive Cancer Center. So Bascom Palmer, from the ophthalmology perspective, started out a little over 60 years ago. And they really, really care about doing a great job delivering eye care. And so we've been fortunate enough over the past 35 years that they've been ranking eye institutes or eye hospitals that we've been ranked #1 for 24 of those years, and every year since 2004. So I've been very, very blessed to train in an institution like this and to work with such amazing people who are here. And the Sylvester Cancer Center is over 50 years old, is the only NCI designated cancer institute in South Florida. And so we're very proud of that partnership. And here at Bascom Palmer, we have 3 dedicated basic science ocular oncology labs. So we are kind of knee deep in research in ocular oncology on a regular basis. And so this is something that's very meaningful to us. Very recently, we opened the Griffin Cancer Research Building through philanthropy of Kenneth Griffin. And this really helps us significantly. It's doubled our research capacity. So it's allowed us a lot more space and opportunity to do some of the groundbreaking research that we hope to continue doing. And so it's really united a bunch of the brightest minds that we have here to help us provide that research. I really want to thank the two leaders of our respective centers. So Dr. Eduardo Alfonso, who is the chairman of Bascom Palmer, and Dr. Stephen Neimer, who's the head of Sylvester. Neither one of them could make it today because they are participating in the Digital Icon, another conference that we're hosting on the undergraduate campus, talking about how we can use AI, large language models, and other educational and technology to better improve our interaction with patients and with each other. So they're very excited to help support this event. I want to give a little bit of shine to our ocular oncology service here. So we have a great group of people. You can see the people that are listed in orange are part of the team that takes care of patients with intraocular cancer. And unfortunately, Dr. Correa couldn't be here today. We heard from the Melanoma Research Foundation about all the efforts that they are doing from an advocacy standpoint. Dr. DiNicola, myself, and Dr. Correa were all in Washington, D.C. the last few days advocating for ophthalmology. And Dr. Correa is on the board of trustees for the American Academy of Ophthalmology. And so she's continuing those efforts through this weekend to advocate for us and our patients. And you will also hear from Sandra DeBovi tomorrow, who is our ocular pathologist. So you will hear a little bit about that. We wanted to give an additional shout out to our ocular oncology team. So our nurses and clinical coordinators who really form the backbone of what we do for our clinical care and with research as well. And so we have a few of them in the audience. If you can raise your hands, we very much appreciate it. Nori, nice and high. Because they make our job so much easier, and they really do so much for us. We'd also like to thank our collaborators at the Sylvester Cancer Center. So the team at the top in orange are medical oncologists, and you'll hear from a few of them at this meeting. And Dr. Jin, our radiation oncologist, and Matt Studensky, who's our medical physicist, who really kind of help us with all of our radiation treatments. And so we're incredibly grateful to them for such a wonderful partnership. Outside of just our coordinators and nurses, we really have a huge team of people that make it all possible, including our administrators. We have an emergency room here that's 24/7. So if patients have difficulties, they have ways to kind of get in very quickly. We talked about our 3 basic science researchers. We have a team of researchers who are helping, including people who are taking time to study before going to medical school. And we have some of them here in the audience. We very much appreciate you and your efforts as well. And they really make us look a lot better than we are. And so, again, we're grateful. We also heard from the MRF team about the Miles for Melanoma. And so we wanted to kind of highlight, what's going on. So Alex Rodriguez is doing AV for us. And this is a little video of his son, who's 14, who's running the Miles for Melanoma race. And you can also walk this race, and you can see in the background there's a little girl following him with a phone, and that's his sister who's also supporting. So Stanley runs on behalf of his. Yeah, exactly. Great family support. And you can see his amazing times here, like 5.5-minute mile pace that puts me far to shame. So after seeing this, I know that I'm going to be in the walk category of this moving forward. And then last but most important, we really wanted to thank all of you, our patients and caregivers. You really are the inspiration for what we do. I actually was planning on a career in finance. I had no interest in medicine, to be completely honest, and a friend of mine's dad was a retina specialist and an ocular oncologist. I spent some time with him in clinic because I was just going to work for a few weeks, get a paycheck before selling my soul on Wall Street. And I saw him interact with a young patient who had a choroidal melanoma. And that really changed my whole trajectory. I saw their relationship and their bond. I saw the way that he was able to kind of comfort her in this challenging time. And I actually got pretty close with her and her family And she was like very thankful for my help. And I felt like I didn't do anything. I was a technician. I just checked her vision in the beginning. But I felt like if I could have any component of impact in that role, that this is something that I really wanted to do. And so I mean it when I say thank you to you, because you are the inspiration behind what we do. You give us the desire to get up in the morning and to interact on a regular basis. The way you approach this disease process with courage and resilience is really inspiring. That partnership that we have, that relationship, it's an honor to try to continue to earn your trust on a regular basis. And we have another medical student, Sean, who's interested in going into ocular oncology, and he's had the unfortunate opportunity to spend time with me. But he has kind of seen your stories, and that's further inspiration for our future generation to improve upon what we're doing. So thank you for the hope that you provide, for the inspiration that you give on a regular basis, and for giving us the nidus to do a meeting like this. So welcome to Miami. Welcome to the University of Miami. Welcome to Bascom Palmer Eye Institute and Sylvester Cancer Center. And we're very much looking forward to a great meeting. Thank you. And Miriam's going to come up and start with our first panel.
Thank you so much, Dr. Williams. Another round of applause because he is so wonderful. We're going to move into our next portion where I'm going to ask all of our panelists for the patient and caregiver panel to please come up. So we always like to start, oh, Ed, the microphone's right in the middle. We always like to start our meetings with a patient panel, patient and caregiver panel. And we do this to really set the tone for the meeting because like Dr. Williams said, we're here because of all of you. We wouldn't be doing this without these seats filled. And so we want to hear from the patients to really set the tone for the day, to really share from their perspective what it's like sitting in their seats, sitting in their shoes, to really help us frame what today will look like and the things that we will talk about and what it means to these people. So this is a representative of all of you. And thank you all for agreeing and being some of you voluntold. But I first would like you each to introduce yourself briefly, and then we'll head into our questions, our pre-planned questions. And then if we have any audience member questions, Ed Sandell back there with his hand up, he will be passing around the microphone. He was on the panel last year, so he knows what it's like. John, would you like to start?
Assuming this is on. Yep. John Davis. I'm a metastatic ocular melanoma patient, initially diagnosed in 2013.
Good morning, Lou Richardson. Initially diagnosed in 2024. In the fall, have had all my care here with Dr. Williams. He's why I'm here.
Hello, I'm Allie Dashow, and I was diagnosed June 1st of 2022. I know I look like I'm 13, but I'm 30, so I was 26 at the time, and I'm from New York.
Hi, I'm Len Walensky, my caregiver to my wife who was diagnosed in October of 2022. And I just want to say if I seem a little nervous up here, it's only because I am.
My name is Paul Sizz. I'm a caregiver to Cindy Schultz, who was diagnosed 23 years ago. So.
I hear Cindy chiming in from the audience. Okay, so we have a few categories that we thought would be relevant. So we're going to start with advocacy and community. So Allie, our young adult panelist, we will start with you. How has being part of the OM community changed your experience with this disease?
Yeah, so I think in a lot of ways, I mean, I think first and foremost, obviously, just like having community, I think is so important. I think for anyone, right, going through anything in life, let alone a mental health, I'm a psychologist, so I don't know why my brain went there, a medical issue, right? And I think especially for a cancer as rare as this. And so, you know, when I think of the word cancer, right, or I think when any of us think of it, right, it's a scary word, but I think because of this community, because the MRF, when I think of that word, of course, I think of myself and, you know, my physical health and future, but I also think of community itself, right? Like I think of everybody here, all the people I've met the last few years since being involved. And I think to be able to, right, I hear the word ocular melanoma, right? And again, I think of myself, but I also think of the amazing people that I've met and the experiences that I've had because of it. So I think just being able to connect with other people, feel less alone, of course, is incredibly impactful. And I think too, especially with such a rare cancer, having community, building connections, meeting physicians here and other people who work in this field, right? I think it helps us and has definitely helped me feel more knowledgeable, be able to feel like I can be my own advocate. So I think, right, on both the ends of like advocating for yourself, getting the best care you possibly can by meeting other patients, learning about, you know, different trials or whatever it might be, but then also being able to, you know, feel more empowered.
Thanks, Allie. Lou, we'll go to you and ask you, since you were more recently diagnosed, what would you want newly diagnosed patients to know about finding community and support?
So you don't know what you don't know. Nobody woke up one day and went, oh, I think I'm going to get cancer in my eye. So you have to ask questions. And it doesn't matter what the question is, ask it. You know, and if you don't get the answer or you're not comfortable with the answer, ask again, go somewhere else. You really have to, as Allie said, be your advocate. You have to start. And I told you I would cry. And I'm going to give you a shameless plug. Dr. Williams was wonderful, patient, kind, funny. So you have to just have to do it. And this was my first time being in the room with anybody else that actually had melanoma and ocular melanoma. And I met Allie and Ellie. They were in line at the hotel and they were talking about it. And so I went, hey, you know, we're all here. And that right there, that first connection was huge. This is a very isolating disease. It's easy to become isolated. So you kind of have to give yourself the nudge. But once you do it and you meet people like all of us, it makes a huge difference. And it all happened so fast that, I mean, we were kind of like looking back at some of the, you know, things that we've been through. Our saying as we went through it was like, well, and here we are. You know, because you get it, you get your biopsy, you get your treatment, you know, you're just, and then you kind of, all of a sudden you're like, now what? And then now what? You're just there. So you do it and you find joy in a lot of different places, but you also find those moments where you're sitting there and you're just like, oh, this just sucks. But as Lynn said, because I didn't take a survivor, I just took a patient, we're surviving.
Thank you, Lou. We're going to move to side effects and living with OM. And so, John, do you want to talk about side effects and managing that and what that's been like for you?
I've had just about every side effect you could probably have, both from the melanoma itself and the metastasis and the all the effects that come from treatment of that. It's something you don't think about when you start down the path. You're just kind of going one step at a time. When you start with the eye, let's move on to whatever's next. And the next thing you know, you've found that and I'll describe this a lot tomorrow, but you've lost a lot of those things that used to be your identity. And that's something you have to wrestle with in that process. And I think I've hopefully figured out a way to do that. But I think the trick is like the melanoma itself. And like Lou was saying, you just take it one step at a time and move ahead. I can't, I've got vitiligo now. I used to tan really well, and everything's turned white. And I'm basically an albino from the neck up. I was at a grocery store in our small town, and the guy behind the counter says, "Hey, do you mind if I ask you a question?" I said, "No, go ahead." He said, "Are you an albino?" And I said, "No, well, kinda, sort of." Not by choice. It just kind of happened that way. But so now, I mean, I would go on motorcycle rides and tan, and wear a tank top, and I'd turn nearly the color of Dr. Williams over here. And now I look like a mummy riding. And when I go out for motorcycle rides, I cover up from head to toe, because anything that hits me, any sun that hits me, is going to turn it into a burn right away. So those are challenges, but they seem easy after you've gone through the other stuff in a lot of ways. And so I think the managing the side effects is just something that comes with the territory. And in the grand scheme of things, it's going through the initial stuff prepares you for going through the subsequent things.
Thanks, John. Does anyone else want to comment about side effects or management?
I guess I can share a little bit. So a year after I was diagnosed, I developed radiation retinopathy in my eye. So I undergo injections every 5 weeks. And I think, there's times where it just kind of becomes your new normal. And then there's times, right, where it's frustrating, where it's like, okay, now I have to take off of work. And now I'm kind of like down for the count for the day. And then sometimes I think like, oh my gosh, like I'm 30 years old. I hope to live a very long time. So I'm like, how many more, right, of these injections am I going to have? And I think sometimes it's scary to kind of think about your future in that lens. So I think I was going to talk about this later, but I think one of the things that I do that kind of helps me manage it from a more like emotional, psychological perspective is just trying to find like the joy in the little things. So some people here have heard me talk about this, but at my retina specialist office, they have a snack cart. I love free food. So I love free food. I'm a sucker for it. So every time I go, right, it's something I look forward to. And it sounds silly, but for me, I'm like, okay, like, now I get to have my free snack. Sure, I'm going to get the needle in my eye, and that's not super fun. But I think so much of it is mindset. Not to say you have to be like happy all the time or positive, but I think for me, just being able to find joy in the small things makes some of the side effects, I guess, like more manageable. It feels a little less heavy, I would say.
And you can, I'll tag onto that just a little bit, because you prompted me to think of something. My youngest daughter at the time, when I was getting eye injections, and had to come home, I said, there's something worse than putting drops in your eyes, getting a needle in your eye. And she says, you can tell a lie now. And because, stick a needle in my eye. And, so I was like, oh, good news, right? There's a upside to everything.
Thank you both. Lou, would you mind talking about low vision or losing an eye?
So,
Hold the microphone closer.
sorry. So I have very limited vision in lefty here. I have just a little peripheral. Before this, I've always kind of, and I just thought not that much about it, had issues with me spatially and stuff. So if you were walking next to me, you knew I was going to kind of list. So you just kind of got used to it. It's just I've always been that way. I wasn't named Grace for a reason, and I'm okay with that. So losing my eyesight, it was quite interesting, because then I became more wobbly. My depth perception is for crap. It just is. I don't drive as much. I've narrowed where I drive, just like kind of what I'm comfortable with. My car has all the bells and whistles about, okay, you're veering. So, I appreciate that. One of the things that I didn't realize at the time that really made a difference, is I went to PT for my wobbliness, because I was like, and it's so interesting that I've learned that how much and it sounds so simple when we say it, how much your vision impacts all of that. So not only are we working on making me more stable, but we're also working on helping my systems, like my eyeballs, talk to my feet to where I'm steadier. And it's very surprising that it made a difference. So, I'm not fun to ride in the car with. I sit in the back seat a lot now because it's just, I'm like, oh, I'm better about saying, I used to be the person that could find anything that was lost. I knew where everything was. Not so much anymore. I'm like, where is it? And I'm thankful, but it's so frustrating when somebody walks up and goes, well, it's just right here on this shelf in the refrigerator. So it's an adjustment. I'm a huge reader. I mean, that is my thing. And that probably was, of all the things, my concern was like, oh, if I can't read, I'm not going to be a lot of fun. I'm not a Kindle person. I'm not a digital reader. I need to hold the book. I need to smell the book. And so fortunately, thank you. I love large print, but that is still, I bring my, I can sit down with a book and I'm just as good. I hold it a little different sometimes, but I still am able to do that. So those are the things that make a big difference. And I've learned to do this. I've broken many things. A friend of mine, she's a blind rehab therapist. She gave me like a metal glove to wear when I cut. I don't chop a lot anymore, but it's just minor adjustments.
And you don't chop your fingers.
I do not. I wear the glove and I don't chop my fingers.
There you go.
And I walk a lot more because I'm not a fan of parking lots, because I don't want anybody near me. So this summer in Florida, I'll probably be wearing a hat a lot, but because it's just easier when there isn't a bunch of things around you.
Thank you, Lou. I'm going to ask Len the same question, but from the caregiver perspective, what it's like living and caring for someone with vision loss or low vision.
It was a learning experience. I had to learn a lot about this disease never heard of, on how it altered my wife's life. Unfortunately, she's basically blind as a result of this disease. And learning that she has a whole new perspective on life, how she envisions the world, interacts with the world, is now totally different than anything I could ever have imagined. And learning to deal with that from my end and to accept the fact that she can't do all the things she used to be able to do, even though she would love to. It's been a hard learning experience for that. I had to learn that I couldn't fix this for her either. That was another part of this. I'm a fixer by nature. I go down to the basement, get my duct tape, get my WD-40, and I fix it. But in this case, I couldn't. And I've had to learn to accept that our lives are different now. Her life is dramatically different. We never expected to go into retirement and this would now be our life, coming to OM supposedly. We thought we'd be going to Paris. That's for Miriam's benefit. London, we'd be traveling. We'd be spending time with family and friends, not coming to these symposiums, which we love. We've met so many wonderful people here, but it was just so totally unexpected, out of the blue. Who ever heard of this? Who ever knew you could get cancer in your eye before this? Bet I could look around and nobody, who ever heard of this disease until you actually got it. So, like I said, it's just been a great not great, but a long learning experience for us in having to deal with this in our new lives now.
Thanks, Len. Yes, Len has been trying to have our Cure Symposium in Paris for 2 years now. So we'll see what we can do is what I tell him
I'll keep talking. I keep
Each-
trying.
each time. So John, we'll come back to you to talk about perspective, because it seems like that's where Len was taking us. How has this diagnosis changed your perspective and how you see things?
I could talk for 45 minutes on that, and I will tomorrow. But I think I would sum it all up in just a few words, and that is, and I've told people this. I may even said it last year. I don't remember that. Everything it's like the world has come into a different kind of focus and brightness, and you appreciate everything. I mean, everything more on a day-to-day basis. But I'll say that if I had lived, I'm an engineer. Engineers aren't outgoing people going out and doing all the interacting things. My engineer friends will, probably confess to that. And so I might have lived to be 85, 90, 95 years old. And I don't think I would have done as much living had I lived that long under my old paradigm than I have in the last 13. So it's fair to say it's completely changed my perspective on life. And I've done, I don't know, I lived more intensely during that time than I probably would have if it were not for this. So that's the pre-plug for I Have Cancer. Yay! For tomorrow.
Yes, John will be speaking tomorrow on I Have Cancer. Yay. I didn't say it as well as he did, but we'll be looking forward to hearing from him more tomorrow. Thank you, John. Paul, do you want to answer that question?
Which one?
How has your perspective changed since this diagnosis?
I mean, my father died of cancer. My mom, when she passed, had cancer. And so watching them and listening to their stories, and also Cindy's, it's not a disease that anybody wants to have, because I'm an engineer by trade, just like John. And you want to solve problems, and you get to the point where you can't solve. You're like, what can I do? You can't solve the problem. As a caregiver, the only thing you can do, and as John pointed out, as an engineer, we have no feelings. So sometimes that makes it easier because we can focus in on the details and remembering the details, because the patient or the survivor is focused on dealing with having the cancer. As a caregiver, you kind of focus in on, or an advocate is focusing in on, what are the details and trying to remember those things so they can make the decisions. Because in the end, the person with the cancer has to make the decisions on how they want to proceed. That's all you can do for them, is just be there as a sounding board. So
Yeah, it's a problem.
that's how I approached it.
Yeah, a problem you can't fix is
Yep.
what we've heard from multiple people. Thank you, Paul. We're going to turn now to surveillance, treatment, and anxiety, which is a buzzword, and you may have heard the term scanxiety as well. So we'll go to you, Allie. How do you deal with the ups and downs of scans and treatments?
So I think I touched on it before, right? Like kind of trying to find like the small joys in everything. Again, going back to food, like my mom always takes me to my injections because I usually can't drive after. So ever since I was diagnosed, so my last name's Dashow. She calls it the Dashow insurance, where every time we go to an appointment, we go and get like a dessert after or something like that. And again, sounds silly, right? But I think there's probably other people who do something similar, right? Where it's like, okay, I need something like positive or enjoyable to look forward to. So I think on the surface, right, like things like that. I think also, I think for me, a big thing that's helped is just like the acceptance of like, I can't change it, right? Like everybody here is talking about, right? It kind of is what it is, not in like this doom and gloom way, but kind of it's like, I don't want to stop living my life just because these are the cards I've been dealt. And, you know, I think just from my own personal experience, also being a psychologist, I feel like you kind of learn in life that like everybody kind of goes through shit, pardon my French, right? Like everybody has just crappy things that happen in life. And I don't know why all of us here were dealt this deck of cards. But I think it's like you kind of make the most with what you have. And I feel like that's kind of what I've tried to do. And so I think that's one piece, right? Kind of going back to like the mindset side of things. I think in addition to that, I think like hope is obviously so important and not in a way where you kind of have to like be in denial and say like everything's going to be fine. But I think, you know, thank God my cancer hasn't spread and I'm very lucky that I'm no evidence of disease. But I think I like knowing the research. I like having all the information. And there's something about that feels, I think, like comforting to me to be like, okay, like I know a lot of the options that are out there if this spreads. And even right now, dealing with radiation retinopathy, I think like talking to different doctors, doing research, there's something about that I think makes me feel more in control when, right, you're dealing with a diagnosis that makes you feel so out of control. And so I think hope is a big thing too. And then I think just like the day to day of just like when I feel sad or when I feel scared, just allowing myself to feel that way. And also knowing kind of like who to go to, right? Because there's some people you go to and they'll be like, oh, everything's fine, right? You're going to be okay. My boyfriend has a joke. He always, whenever I have my scans, he goes, I got the report from the doctor. You're fine. And he says it as a joke. But also him or other people in my life, knowing who I can go to, who's just going to sit there and listen, right? Paul, like you were saying, of like knowing, right, you can't always fix it. And I think for me, kind of seeking out those people who I feel will just listen. And just to know that someone hears me and acknowledges like how hard and scary this is, I think for me, that really helps. Like I'm someone, if I just like let it out and talk about it, it kind of like helps me move through those feelings.
Thanks, Allie. What a great perspective, and also sharing like trying to find what you have power and control over in a very uncontrollable situation. Lou, I'm going to ask you the next question, or which is, what deliberate actions do you take to avoid spiraling into anxiety or feelings of depression?
So, and that's really important, obviously. But I want to say too that it's vital, just kind of like Allie said, to feel the feels. You're going to be sad. You're going to be confused. You're going to be shocked. You're going to be mad. You're just, you have to acknowledge them, because if you don't, they're going to jump up and bite you in the butt. I have kind of a warped, twisted sense of humor. And I'm fortunate, no, it is. And I'm fortunate that one of my sisters, my older sister, is kind of the same way. So we say things to each other that would probably shock a lot of people. We find humor sometimes where others weren't. So I can talk to her and we can joke about stuff and laugh to the point where we're like, okay, stop talking or I'm going to pee myself. And it really helps. And I've also realized that with the going for the scans, I tend to to compartmentalize it. And I'm just like, I just have to get through it. And not that I'm going to offer this suggestion to anybody, because then by the time I'm done, I'm a mess. And I was like, okay, that wasn't the best way to handle that. The first time I ever walked into Moffat in Tampa for my scans, I walked up and I stopped outside the building. I went, oh my God, everybody in here has cancer or is affected by it. And I thought, really? You just now realized that, you know? So I think you need to be aware. If you need to have that, and I'm a social worker by trade, so a therapist by trade. If you need to have that pity or that anger or that whatever, allow yourself to do it, put a timer on it, and then have a plan to move to the next thing. And the shower is the best place to scream and cry and holler because the water's running and you don't really have to worry about anybody hearing it. If it's those, if it's those few people that aren't as okay with that.
I like that. Thanks, Lou.
Can I share a quick anecdote?
Sure.
Because we were just talking about humor, and right, like this might not be for everybody, but I think for me, like that's something that's helped me and my family so much. Because right, like I feel like the word cancer, like I was saying before, right, it's such like a scary, heavy word. And I think like being able to just laugh or make a really dark joke or whatever it is. And so it reminded me, so I'll just share this briefly. My mom, thank God, is okay, but she was recently diagnosed with lung cancer, so she underwent surgery. And I'm a big proponent that if you have cancer, you might as well play the cancer card to some extent, right? And so I texted my family the other day, and this I think kind of gave us all a good laugh because she underwent surgery like a month and a half ago. And I basically told my family, I wrote in our group chat, I said, Mom, I imagine you felt very frustrated and upset with everything you've been through with surgery and the cancer diagnosis, and you've probably thought, why me? And I'm here to tell you why. And I basically proceeded to say that my Macy's credit card I thought was on auto pay, and it wasn't. And I had a late fee, and I called them up and I explained that there was a lot going on with my mother. I was like, she just had surgery, unfortunately, for lung cancer. And the person on the other end of the line was very nice, waived the fee, said he was praying for her. And I said to her, I was like, everything happens for a reason. And so, the lung cancer was to help me get this like credit card fee. And it gave us all a very good laugh, I think, in a time where she really needed it, I think, the most, just because she's kind of been going through the thick of it. So
Thanks for sharing that, Allie. We're going to move to some caregiving questions before we get to audience questions. So audience, you could think about your questions right now, but we're going to turn to Paul and ask him, and Len, you can answer this question too if you'd like. How do you care for yourself as a caregiver?
Well, my philosophy is you have to take care of yourself before you can take care of somebody else, because you have to be there for them. And you physically have to take care of yourself, and mentally you have to take care of yourself. And for me, it's cycling and skiing and doing outdoor activities, live in Colorado. Mentally, you do things that take your mind off of, what they have, so you can keep your mind strong. And at times you'll find, I'll find myself just going down the, rabbit hole of, I'll read something about, melanoma or ocular melanoma or cancer or whatever. And you start going down rabbit holes and just start doing research. As an engineer, that's what I did, is do research. So it's just kind of fundamentally there. But as I said, you have to keep yourself strong so you can help, the patient. And you have no choice, because you have to be there for them. So.
Absolutely.
Yeah. Just to piggyback off what Paul said, in addition to everything he said, I also found that I had to accept it's not something I could do by myself. I needed help to keep myself strong, to be there for my wife. So I had to reach out to find support groups, people that I could share what I'm feeling with in a safe space. Finding organizations like CureOM, where I could meet other people that are sharing the same things and going through those same things, and not trying to do it all by myself, because that just wasn't working. That was just driving me down a rabbit hole, and then I couldn't be there to help support my wife. So that was just something else I had to do, in addition to making time for myself, getting out of the house, leaving, going to the gym. I'm a big D&D player. Make sure I play D&D twice a week, or twice a month. I used to play twice a week now. But yeah, getting help, getting additional help, being able to talk to people about what we're going through in a safe space. And I would urge everyone to find some sort of support group in addition to the wonderful resources that we have here.
Great, thank you. I'm going to open it up for the last 10 minutes before our break to the audience, and Ed will be passing around the microphone. So do any audience members have a question for the panel? Oh, Julie, right here. Also, I'm sorry, Ed. I didn't.
Is this on?
Just on.
So my name is Julie Van Wagenen. I'm the one with the tough last name. This is my first time coming to Symposium. For those of you that I sat and eat dinner with last night, this is way out of my comfort zone. I'm a quieter soul, but I've loved being here with all of you. I want to thank each of you on the panel for being willing to share your story. I'm not going to look at you, Lou, because I am a crier too. So I appreciate your vulnerability and you're willing to answer some tough questions. And I think the question that I was wondering if any of you'd be willing to speak into, I'm coming up on my 1 year of diagnosis. And I think early on I was, I've got a wonderful support network. I might be here at the conference by myself, but I've got a wonderful team back up in Massachusetts. But I think I'm grappling with how much to share or what to share kind of as I go further down the line. I guess it kind of makes more sense in my head, but I think early on, I think each of you spoke into, or I think all of us probably spoke into, there's a lot that happens. And so I was trying to communicate well with my friends, with my family. But I'm just wondering, like, if any of you have kind of figured out that system for kind of, I guess, it depends on your family and your friends, how much they want to hear, but I'm curious because that's something I'm kind of grappling with. And if no one answers that, that's okay. I'll just continue to wrestle with that. But I was curious if any of you had thoughts.
Well, I can tell you when I started down this whole thing was like, how do you tell all these people that want to know what's going on? And you can take 4,000 phone calls and go through the same thing 8 million times, right? Instead, I just put out an email update and sent it to anybody I thought would want to know or care, coworkers, friends, family. Said, hey, here's what I've just recently done. And I've gone from stage X to stage Y or whatever it is. And here's kind of what I'm doing. And here's what I'm thinking about in the process. And from that, a couple of things happened. One, I think, I don't know, because I don't know what the alternate future would have been had I done it differently, but I think it cut down on a lot of the having to answer calls and go through all the stuff over and over again. But at the same time, people felt comfortable writing back and not necessarily having to call and sending their hopes, prayers, encouragement, thoughts, whatever it was. And that was, it was a benefit I didn't expect, but that I got out of that process. And it kind of all happened at once. You're in this mode of trying to get through these things. It's like, oh, I should probably take some time and update everybody as to what's going on. So I sit down and just reply all to the last one I sent. And now it's a chain of here's everything I've said and gone through in this process. And here's what I'm thinking about, here's what I'm doing. And then I'm kind of, I don't want to say done with that, but I've gone through that and set it aside, and now I can go on and do the next thing. So it takes a little bit of the mental stress of how to keep people informed and whatnot. And for me, the way my mind works, and Lou and Allie may be different, being engineer to social worker, psychologist is probably complete opposite ends of the spectrum. But I could kind of isolate that and move on, which worked well for me.
Cindy has a question. Oh.
But for me, I did do emails as well. But when I went back to work, after all the treatments and after every tumor and everything else, I had coworkers ask me, how am I doing? What was happening? Where was I at? And I would always give them an answer. And I had coworkers say, how do you do this? how do you stay so calm? How do you keep telling the same story over and over and over again? And my response was, they wouldn't ask if they didn't care. And so with that perspective, it's very easy to repeat the story over and over and over again because they're asking for a reason.
Sorry, it's not a question, but it's an answer as well. I just realized I didn't think of this before, but after I got diagnosed, which is almost 3.5 years ago, I had to tell one person a day or my head was going to explode. But I would only tell people if I knew they wouldn't respond by going, "Oh no," because I just could not handle that at all. And so, wait, there's something you just said about, and what I do now, it's a really easy line that stops the conversation and gives the entire conversation at the same time. I say, yeah, 3 years ago, I was diagnosed with cancer in my eye, and it was the greatest thing that ever happened to me. Next. That's it.
You can talk more with Stephen if you want to hear more.
This question may come under the category of I listened to Anderson Cooper just a little too much. But I want to ask the panelists, both caregivers and patients, there is one side. I'm a very hopeful person and I wake up grateful every day. But how do you handle your grief? Because I have grief. I've lost a part of my body. I no longer have that eye that was so sick. And I really feel so grateful to be here, to be almost celebrating my 3rd anniversary. I thought I'd be dead by now. I mean, that's a terrible thing to say, isn't it? But I really did. The way my prognosis was, I was like, oh, I hope I get a year or 2. And here I'm going to be 3 years and no metastases. It's like a year. So that is my question. How do you handle that big thing that says, oh, I'm at risk?
I guess I could share first. I think it's so interesting, right? Because I feel like there's so much like grief that we experience like about the future in a way as well, of like the grief of kind of like what if. And Ellie, who's right over there, who's around my age, she and I were talking about this, I think last night. Cause like I'll kind of go down that spiral at times, of course, of like, I hope to have kids one day with my boyfriend, right? And I think about, okay, like, what if I'm not here? What if I don't get the opportunity to do that, right? Like, I can't wait to hopefully be a mom one day. And like, I adore kids. I was like a nanny for many years when I was in grad school, and they just like bring me so much joy. And I feel like growing up, I never thought of like being a mom. And then a few years ago, I was like, oh my God, like I want this more than anything. And I hope that I'm here, but I go down that spiral of like, what if I never have that? What if I'm not alive to have grandkids? What if, I have all these like career aspirations? And so I definitely, deal a lot with kind of like the what ifs. And I think what helps me the most is honestly just talking to other people in the OM community, because as much as I can turn to my boyfriend or someone else, right? I think it can be hard for them to kind of go down that thought spiral with me, which I don't blame, right? Or they might be quick to be like, but like hopefully everything will be okay. But I think like being in our shoes, it's hard not to kind of have those thoughts of like, what if it spreads? What if this? What if that? And so I think the thing that's helped me the most is just like talking to other people who genuinely get it and who aren't going to be quick to, I don't know, try and put a bow on it and make everything perfect, just to kind of like sit with you and be like Ellie and I were talking about last night, like we both kind of have those thoughts. So I think for me, like I've learned like there's nothing to kind of like do with the thoughts, or kind of like the fear and the anxiety of it all, except just kind of like talking about it, feeling it. And I think it's like, as much as like, I've definitely had those times of like, I'm just going to try and shove this away, right? I think it's like kind of always in the background in a way, right? Especially when your scans are coming up, or I don't know, someone's talking about cancer, right? Like I've had times at my jobs where we've had like grand rounds and, the word cancer comes up and it's like that trigger of like, oh my God. And then you just start to kind of like go down that rabbit hole a little bit. I don't know if that's helpful, but that's kind of what I find myself doing.
And And I mean, you can't ignore it. Again, you have to feel the feel. This is our reality. This is our walk. It's going to be different for each one of us, but it's also going to be the same. And like she said, you can talk to people who are going to understand, or you can talk to that person that will just listen. There's days that it just sucks. And it sucks. You can tell me it's okay. You can tell me it's great. I'm going to look you in the face and go, you know what? I'm not necessarily arguing with you, but today it sucks. So I'm going to take my day. It's going to suck. And then tomorrow it's going to be less sucky. But you have to acknowledge what's going on. And I think grief, and I didn't feel the anger, which was really quite interesting, until just a couple months ago. And I was like, oh my God, I'm really mad. I mean, I'm like mad. And it really, really surprised me, because I'm typically the kind of person that if something upsets me, I'm going to tell you about it and then I'm done. Oh, ooh. I was like, okay, dog, people around me, partner, caregiver, you might just want to just give me a little space, because I could have thrown things. I could have, the whole thing. And after that came some grief. And I was like, okay, I had to get mad, and now I have to be, and I had been sad. Initially, you get the diagnosis and you cry from your toes and you go, what did I ever do? And just all of those things. But you have to just, you have to feel it. You kind of get to that place of acceptance. This is it. We can't change it. You give up the control, which we never had any to begin with. And then you do the things that make you feel a little better, and sometimes they're the simplest things, you go for a walk, you get a manicure, you watch a funny movie, you watch a sad movie so you'll cry and you have a reason to cry. And then that really helps a lot, because you're like, ooh, and all of it comes out and you're like, okay, that was just a really sad movie, but that really helped me. So you just, kind of got to feel it.
That was the woman's answer.
Oh,
I'd say a little bit like Allie was talking about with respect to, I got to go through the scan and I've got a reward, in there. When I'm kind of feeling, the negative aspects of everything, it's like, okay, what can I do to shift my thinking into something different and something that's positive with respect to this thing that I'm feeling sad about, right? And as an example, I started thinking about the fact that I'm probably never going to see grandkids, but I've got nieces and nephews who have kids. And that's part of the reason I moved to South Dakota, because I get to be around my grandnieces and nephews, which are my replacement grandkids, hold them when they're born, show them stuff, do fun things. And that was a replacement for me for this thing that I was losing in the process. So I think there's a lot of things you can find that are positive aspects. All of them don't work out. When I was thinking about, okay, so I'm probably going to die in the near future. At least I don't have to watch my parents die, although it's sad that they'll have to watch me go. I don't have to watch, friends and acquaintances, all these people. And then it turns out I lived so long. I buried both my parents. I buried my best friend from high school, buried one of my good friends from my engineering work, one of my good friends from my Air Force work. And here recently, a few weeks ago, I had a sister who was undergoing surgery and everything went kind of haywire, and she ended up coding like 3 or 4 or 5 times. And I was like, oh, please, God, I'm embarrassed. This is my first thought, not a sibling too that I have to bury. And she ended up recovering. And after I got over my little grief with myself, then I was able to focus my attention and thoughts to her. But the point being that you can find, at least mentally, those things that are advantages or things that you can do differently that maybe get you out of even having to have that grief again, because you've replaced it with something positive.
That was pretty touchy-feely for since you brought it to the table. That was pretty touchy-feely.
All right, with that, I want to thank all of our panelists. And thank you, Ed, for passing the microphone. Sorry, he just had a knee replacement. I probably shouldn't have chosen him for this job. We're glad you're doing well. Thank you all so much. We're going to now have a break until 9:45. And at that point, we'll come back and we'll hear for our first session on understanding uveal melanoma. And we have snacks outside. So go to the bathroom, grab a drink, a snack.
All right. That was a phenomenal first component of the meeting. A nice break, opportunity for bathroom and refreshments. And now we'll get back into it. So for this talk, I'm going to be going over understanding uveal melanoma. Feel free if you want to interrupt, raise your hand or speak, and then we can have it be more interactive, or we can have questions at the end, whatever you all feel comfortable with. These are my financial disclosures, none of which are relevant, or I do get research support from Castle Biosciences. So uveal melanoma. This is a rare condition, but it is the most common primary malignancy in the eye. About 5 to 6 people per million in the United States. So yes, fairly rare, but it doesn't feel so rare in this room, obviously. About 50% of cases are asymptomatic and it's rare to have pain. And so here you can see the eye, and involving the iris is a low number of cases, involving the ciliary body also a low number of cases, and most of the cases are found in the back part of the eye or in the choroid. When we look at the breakdown a little bit more, men are more likely to present with symptoms and women are more likely to present on routine examination. That's presumably because men don't take care of themselves as well. And so they only show up when things are bothering them. We've seen a wide range of patients, at least in our practice. The youngest we've seen is a 4-year-old, the oldest diagnosis 101, so it can be a wide range, even though around 60 years old is when most of the diagnoses are made. It is much more prevalent in people of European ancestry, lighter colored hair, lighter colored eyes, more likely to have uveal melanoma. There's a number of risk factors that are potentially associated with this. Ocular or oculodermal melanocytosis is one. We'll talk briefly about that. I'm not going to get in too much to BAT1 predisposition syndrome. We are going to have a separate talk about the inherited conditions associated with uveal melanoma. An interesting UV light does not have a relationship with this. Dr. Harbour, who we'll talk about a little bit, kind of studied some of the UV signatures and tumors, and we don't actually see that relationship. So even though we think about UV light a lot, there may not be a relationship. So what is oculodermal melanocytosis? And this is basically where you have increased pigmentation of certain parts of the eye and sometimes the skin around the eye. So if you look at this iris, you might say, well, it's a pretty dark iris, not much to think about. When you look at the other eye, you can see that there's actually a big difference between the two, so there's some asymmetry. And so the left eye here, I guess you can't see it. But anyway, the darker eye is the eye that's affected. And so this is something that you can actually notice. If you see somebody that has different colored irides, it may be something that they have never been told about. And so because there's an increased risk of melanoma, it's especially important for them to get their eyes checked. You can also see some of these mammillations, so these little tiny bodies on the surface of the iris. And when you look in the back of the eye, you can see a difference in the color here. You can see one is much darker and the other one looks quite a bit more orange. And so that increase in pigmentation is also associated with an increase of melanoma. Not only does it increase the risk of melanoma, about 1 in 400 compared to about 5 per million, but you can also have glaucoma. One of the things that's important to note, there's an increased risk of metastases when you have an underlying ocular dermal melanocytosis. And so this is an especially important reason to try and have regular exams. So if something is found, you can try and treat it as quickly as possible. You can also see this sometimes just isolated in the back part of the eye. And here's what it looks like in comparison. So you can see a scan through the retina. In the middle is an OCT scan, and that's of the left eye, which is the eye that is unaffected. When you look by comparison to the right eye, you can see that the area in the bottom part of the picture is much thicker. And so there's already an increased thickness because of these cells. And here's another example. This is a very, very thin looking choroid on a person with myopia. And then even though this is relatively thin, by comparison to the other eye, you can see that it is thicker. So these are things that we're looking at and paying attention to. Now, we'll start off with iris melanoma. So this is only seen in about 5% of cases. The diagnosis is often made fairly early because it's on the colored part of the eye. Many of you can see this in the mirror when you look. And so it's something that can be diagnosed fairly quickly. It's usually elevated. Sometimes there will be blood vessels that are feeding it. And when you see these big angry blood vessels, that's an indication sometimes that the tumor is telling the eye, I want to breathe and I want to eat. So make me some blood vessels that are large enough to bring those things to me as I continue to grow. You can see tumor shedding where you can see cells on different parts of the iris. So it's not only in one area. You can see on the blue iris there on the left-hand side of the screen that you have brown areas in multiple locations. This does have the best prognosis of anywhere in the eye, and we're not quite sure why. It may be because it's diagnosed earlier. It may have some different characteristics to it than ones that are in the back part of the eye. And it can present in a number of colors, sizes, shapes. So if this is noted, obviously come in early. This is an example of a patient who had an iris nevus, so basically kind of like a mole. And that was there for a long time. And at some point, a melanoma developed in the mole. So you can see that vascular area inside the brown area. They ended up getting treated with radiation. And you can see that the melanoma actually completely melts away while the nevus or the mole component kind of stays in place. So here's one example of the treatment. And you can see many, many years before that the nevus was present. Then we have ciliary body. So as we kind of move back in the eye, the ciliary body, it's actually the hardest to identify these because they're hiding in an area where you can't see when you're looking directly in the back of the eye, but you also can't see when you're looking in the front. So it takes the most time to diagnose these because they often have to grow large enough to either cause a vision problem or become visible to us when we're taking a look. And so these tend to have a more advanced or more difficult prognosis, maybe because they've grown for a longer period of time, maybe because they have some different characteristics. Some other things that you might see, we often find people that have a cataract just in one eye. And it might be because that tumor is growing and touching the lens and is starting to cause a cataract. You can also see where it can start to grow outside of the eye. Or you can see that there are some abnormal blood vessels there, indicating that underlying those blood vessels is a tumor that's growing. And then you have choroidal melanoma. And these are tumors that are located in the back of the eye. They're the most common by far. How do we make this diagnosis? So the collaborative ocular melanoma study was done in the 80s and 90s, and it showed that just by looking and taking pictures, we're right about 99% of the time making the diagnosis. You might wonder why you go to the office to see your doctor and you're in there for 3 hours, or in my clinic, 4 hours, or sometimes longer, waiting for all of these images. Well, the reason is because they really help us not only to make the diagnosis, but also to follow people after treatment to see how the tumor has responded. So here's an example of a somewhat subtle melanoma, and underneath there's a bunch of fluid. Can you see the fluid? Not so easily, but here it is. We also get autofluorescence because it helps highlight that fluid, and the OCT shows the fluid under the retina really well. So even on that initial picture, when you may not have seen it, getting the additional imaging helps us. It also helps us put it up on the screen, show you the pictures side by side so you can see how things look. Here's an example of an ultrasound. This is what we call hollow, where basically the center part of the lesion looks darker more than the borders of the lesion. And that's often what we see with melanomas. And on the OCT, we can see fluid. Here's another example of fluid that's associated with the melanoma, and you can see the fluid on the ultrasound. We don't need to go through all of these cases, so we'll skip through a couple of them. But ultrasound is something that's really helpful. Definitely a weird sensation. It takes a long time to do. I've had a few of them done on myself so I could understand what you're experiencing. And I must admit that I don't have to try hard to contain my jealousy on the ultrasounds regularly. What about choroidal nevus? So has anyone here had a nevus first that then changed into a melanoma? Yes, I see some hands raised. So one of the things that we actually think about is identifying the characteristics that mean that a nevus is most likely to change into a melanoma. Number one, so we can make sure we watch closely. And number two, if it does change, we can be on it and treat right away. Nevi are things that are fairly common, and we see them in people all the time. The same way you're more likely to have a mole on your skin if you have light-colored hair, light-colored eyes, and freckles, similar in the back part of the eye. It's very, very rare for them to change, but obviously if you're in this room, it has changed. So Dr. Don Gass was a retina specialist at Bascom Palmer, and he's widely regarded as one of the fathers of modern retina. And he actually came up with a bunch of characteristics to help us identify nevi that were concerning versus ones that weren't. And there are some factors here that he associated that were good, and some factors that he associated were more risky. And this has also been put into a mnemonic by the Shields team in Philadelphia to find small ocular melanoma using Helpful Hints Daily, which is something that all the ophthalmology residents kind of learned and memorized so they could understand the characteristics they should be paying attention to. So obviously, the thicker a lesion is, the more likely it has fluid. If it has some orange material over it, etc., that helps us understand the risk for turning into a melanoma. And then when I was a fellow, we kind of updated this using imaging because now imaging is something that we're doing much more commonly than before. There's also two other great models to help people understand the difference. One is called the MOLE system, and this is used predominantly in the UK. And then Arun Singh, who hosted the meeting last year in Cleveland, also has kind of an online risk calculator to help understand what the risk is of a small lesion being a nevus or being a melanoma. So we'll just go over a couple of pictures so you can see the things that we think about in this process. So here's an example of a nevus. It has all these yellow spots over it, and those are called drusen. They're signs of chronicity, basically meaning that it's been there for a while. I kind of like to think of it as a kid who doesn't want to do his chores and sweeps a bunch of stuff under the rug to act like things are clean. That's these little bumps that you see there underneath the retina. And that kind of lets you know that the lesion has been there for a while, rubbing up against the retina, and you kind of accumulate these changes over time. You can also see some other changes that indicate chronicity, so kind of a yellowish green pattern over the top of it or some black pattern over the top of it. And actually, you can see some bleeding over the top of nevi as well, and that's usually a sign of chronicity. Melanomas tend to grow too quickly to develop this kind of bleeding. So we talked about pictures, fundus photos. Here's an example of a patient with a lesion, and over time you can obviously see that it grew. And so we can put these up side by side and we can show you guys what it looks like and what we see. It's also really helpful for us. If I take a look at a patient and I see this, and 6 months later the lesion looks like this, can I really tell that it's grown? It's very subtle. But when you magnify it and you look at the borders compared to the blood vessels, then you can see very subtle differences and we know that it's grown, and that helps us move forward with our treatment decisions. Ultrasound is something that we use pretty regularly. Obviously, it's quite easy to see on ultrasound a difference between the top picture and the bottom picture, and the fundus photos also show that this lesion has grown. But it is helpful for us to see that. It also helps us see other things. So in the bottom pictures, there's extraocular extension. So on the ultrasound, you can see sometimes if the tumor has grown to the point that it's actually starting to push outside the eye, and that helps us choose our treatment appropriately. The autofluorescents are kind of those black and white pictures that we showed, and we've talked about orange in the past. Orange is not really orange. On dark lesions, it looks orange. On light colored lesions, like you see here, it actually looks brown. I've had a number of patients question my ability to see color when I say it's orange. So I would like to say that I can differentiate them. But on autofluorescence, you see them as bright white in either situation. And so that's something that's helpful for us to identify. We talked before about seeing fluid, and the autofluorescence shows that fluid nicely, where on the color pictures or sometimes looking in your eye, it's hard for us to see. And then the last thing that we do from an imaging perspective pretty regularly is OCT. And this is where we get a scan through the retina and you can identify fluid very quickly and very easily. So this works most of the time, but sometimes there are really subtle lesions that it's hard to tell if it's a nevus or if it's a melanoma. And for a long time, and still today, sometimes we just watch them and we see what happens over a few months. And if it grows in that short period of time, well, it's more likely to be a melanoma. Nevi can grow, but usually they grow very, very slowly. However, we can also do biopsies of these lesions, and that can help us understand whether or not a lesion is turned from a nevus into a melanoma, and it helps us understand our prognostic information. I should have given you a warning that I was going to show you this picture up front. I'll do that next time. So here I want to stop very briefly and kind of give a shout out to Dr. Bill Harbour, who was the ocular oncologist at Bascom Palmer for some time. When I was a resident here, he was practicing here and heading the service. And so through his research, actually, he kind of created a group of 12 centers, 450 patients or so, called the Collaborative Ocular Oncology Group. And that helped determine which tumors were a high risk of spreading to other parts of the body and which tumors were a low risk. And that's how we understood class 1 versus class 2. Very helpful defining characteristic, and we use our biopsies to kind of help understand how often we should do scans in the future, whether or not you might be eligible for a clinical trial, because if you have a more of a high risk, then there's a higher likelihood of spread. And so if there's side effects from clinical trials, we want to make sure that we have the right population to be looking at these things. More recently, we put together the Collaborative Ocular Oncology Group 2, and we did a study, and this was a larger group of people, 25, 26 centers across the US and Canada. That's why the circle above is above the United States. That's not misplaced. And this was over 1,700 patients over a 3-year period, so a much larger cohort. And this study was actually really helpful because the first study mostly had very, very big tumors. And they were very big because we were removing a lot of the eyes at that time, which we still do sometimes. And then we were gathering information from that. And so it kind of skewed the data, because if you have really, really large tumors that maybe had more time to grow, you might expect that they might be more aggressive. Now, including patients that are earlier in the process, you get more realistic information of what patients are like when they come in. Some come in with itty bitty tumors and some come in with very large ones. And so now we have better information to kind of discuss what the risks are for metastasis. So there are a couple of papers that were produced from this. And we looked at gene expression profile, so class 1 versus class 2. We also looked at PRAME, which we'll talk about a little bit more. And we've published 2 reports on this so far, and there's going to be many more coming. But the first one, again, looked at prospectively GEP and PRAME, and the second one looked at the other mutations that you can actually see in melanoma, which helps us sometimes make the diagnosis. So again, through Bill Harbor's lab, we've gotten to understand how melanomas develop. So they start out as a uveal melanocyte. So that's basically a cell that you can see in the uveal tract, so in the iris, the ciliary body, or the choroid. What happens to go from a regular cell to a nevus? Well, it has to develop a mutation. So there's a few mutations that they can develop. So every mole, every nevus has these precursor mutations in them. And many times it's just the nevus that's quiet and may never change. Some of them are going to turn into an active nevus. And that's based on some copy number variations, which we don't need to talk about so much. But once you have an active nevus, you can go in a couple of directions. An active nevus has a likelihood of turning into a class 1 tumor, which is a low risk. And in those situations, you see certain types of second mutations, EIF1AX, SF3B1. So those second mutations tend to indicate a better prognosis. Or it can turn to a more aggressive type of tumor, which is often associated with a BAP1 mutation. Then after that, PRAME is a modifier. So you say, the first thing we need to know, class 1 or class 2. Class 1, good news. Class 2, not as good news. And then you look at the PRAME status. If PRAME is negative, good news. If PRAME is positive, not as good news. When we looked at the most recent study, you can see here what survival is based on the class and PRAME status. So class 1 PRAME negative, really, really good outcomes, 96% at 5 years, versus class 2 PRAME positive, lower. What is PRAME that I keep on talking about? It's preferentially expressed antigen in melanoma. We use a bunch of acronyms in ophthalmology and ocular oncology, and to be truthful, none of the other doctors know what we're talking about either, so we have to translate it for them just as well. This is a gene that's not usually seen in human eye tissue. And so it can become active in certain cancers, and when it's active, it basically means that you have a higher risk of metastasis. Only about 30% of underlying uveal melanomas have PRAME activity, but when it's present, it's something to pay attention to because it is a little bit of a higher risk. And so now we have a better understanding. I don't have to go through the whole video again, but we have a better understanding of the pathway of a uveal melanoma. Now, why is this helpful for us? For a few reasons. Number one, we talked about biopsy. So we look at cells under the microscope to see, is this a nevus or is it a melanoma? Sometimes they can really look similar. I also know, talking to some of our pathology colleagues, if they can't tell very easily, they might be more likely to say, well, I think it might be more likely to be a melanoma, because they don't want to miss a melanoma and say it's not a melanoma. So maybe that means that we evaluate more on the aggressive side. Looking at these mutations, if you do a biopsy and you see the first set of mutations, the GNAQ, GNA11, PLCB4, CYL, CYS, LTR2, we know that that's at least a nevus, at least. If you see the second mutation there, it's a pretty good indication that it is a melanoma. And so let's say you're a very anxious person and you have a small lesion and your doctor says, well, let's wait 3 months and see whether or not this changes. And you're like, every night for these 3 months, I am not going to be sleeping, wondering what's going on with this lesion. Well, sometimes biopsy can be helpful in that situation because you can get the answer in a few weeks, at least theoretically in a few weeks. Most of the time it comes back very quickly. Occasionally it doesn't, but you get the results back very quickly. And then you can have an informed decision to say, yes, it's a melanoma. Now I know that I'm going to move forward with whatever the next step is. No, it's not a melanoma. Or maybe you can't say for sure one way or the other, but at least you say, okay, it's not definitively a melanoma, and so we can follow. And so this is something that has been very helpful for us. It's also helpful because now it gives us some targets. So let's say you're PRAME positive. You can work on identifying medications that will target PRAME, and that gives us specialized treatments. You can look at certain medications that target the G protein, so the first group of mutations. And we will hear throughout the course of the day some of the clinical trials that are focusing on these targets. So it is very helpful to have this information as well, so that way we can choose appropriate treatments, and we can work with our industry colleagues to identify medications and treatment options that work on some of these targets. So I will, yes, please. This is taking place in the eye.
Dr. Williams, if you could kindly repeat any question that's being asked just
Yes.
for the recording purpose.
So the question was, where is this taking place? Is it in the eye or in the liver? It is taking place in the eye because in order for this to go anywhere else, it has to be a melanoma first. So when we say melanoma, we mean a malignant lesion which has the ability to go to other parts of the body. And so it has to go to the point of being a melanoma in order to be able to escape the eye. So the question was, he only gets checked in his liver and lungs. Should he be getting checked in the eye as well? So I would say there's a few things. Number one, we chatted a little bit about this. When you get an enucleation, when you get your eye removed, you say, okay, my eye is removed, the cancer is gone, I shouldn't have any risk of metastasis at this point. What we realize with melanoma in general is that these can micrometastasize. So when it becomes a melanoma, it can send out small cells or seeds to other parts of the body, and they may just remain dormant. The reason understanding class 1, class 2, and PRAME is helpful is because that lets us know if those seeds may change over time. And so even if you've already had your eye removed or you've had successful radiation, the tumor can no longer send out seeds after treatment. But before treatment, there's the possibility of sending out seeds. So that's why you need systemic scans. For your question about the eye, we do find it helpful to have eye checks on a regular basis. Number one, because even though radiation is extremely effective, 95 to 98%, there are some situations in which the tumor can come back. And so we do need to monitor for that. It's more uncommon after enucleation, but it can rarely happen. So occasional eye exams are helpful then.
So related question, is all of this information available for metastatic tumors? Reason being, I did my Castle thing way back when they would do PRAME and all those sorts of things. If I did a biopsy of a metastatic tumor, will it give you this information since we can figure out trials or trials?
Yeah, so the question was, based on metastatic lesions, can you identify this information? So there's a slightly different profile between the melanomas that we see in the metastatic setting versus what we see in the eye. In the eye, this is helpful for us to understand risk of metastasis. Once you already have metastasis, it's not so helpful to have the information about the risk because it's already happened. And so there's kind of a different profile and things that you'd be looking for and evaluating to understand what would be the best treatment options. And as some of our medical oncologists talk a little later, we'll be able to dive into that a little bit more. 1, 2, 3, 4.
So quickly, so I wasn't able to have a biopsy, so you might talk about this later. Talk about stuff with DNA analysis.
Yes, we will talk about that a little bit later. We'll get back to that. I will say, from a testing standpoint, if you have had treatment and did not have a biopsy before treatment, we do not have a good way to get that information afterwards. For many, many years, we went based on size, shape of the tumors, some other characteristics to understand the risk prognosis. And so that's kind of still what we're doing in those situations, but we'll talk a little bit more about circulating tumor DNA.
Class 2, PRAME positive as I am, and Castle did my genetic testing, and I go every 3 months for the MRI and for the test, although that the alternating X-ray and PET scan now. Is the only way to protect yourself to have the MRI and PET scan? Is there anything else that I can do?
So fantastic question. I will also state here that none of the information we're giving is personal, individualized advice, but we are talking about very general situations. So if there was a person with a class 2 PRAME positive lesion and a VAP1 mutation, there's some things that you can do. There's not like great data on this. So first answer to that is we don't really know. Second answer to that is we think that microenvironment in your body plays a role in what happens to these micrometastases if these develop. So the better your immune system is, maybe the better off you do. What does that mean for nutrition and sleep and health otherwise, exercise? Those things are probably helpful, but we don't have a lot of granular data on that.
I'm simple. So you have a 60-40 class 1, class 2 split. You have a PRAME positive, positive or negative split?
About 30% overall have PRAME. So 70% no, 30% positive. Correct. Eleanor? Still have a question? Oh, okay. All right, perfect. So the question was, if you make a clinical diagnosis of a melanoma and you do a biopsy and it's suggestive of a nevus, do you then change course? So what I would say is the vast majority of time we're making the diagnosis of a melanoma clinically, and we're doing the biopsy for prognostic information, not necessarily for diagnostic confirmation, or for both at the same time, but you're often moving forward with treatment at the same time as biopsy. When you get a biopsy, there are some situations where you'll get a G protein mutation, so that first mutation that says it's a nevus, and you don't get a secondary mutation. That does not mean that it's definitively not a melanoma. It means that we did not see a second mutation. We may not know all the types of second mutations yet. We may just not have gotten it in that situation. So we can't say definitively. So I think it would be extremely unlikely to be in a situation where clinically it's a melanoma and then the biopsy has us coming back saying, actually, it's not a melanoma. And I think we'll do one last question and then we'll go to the panel.
Yeah, sorry. Asking a question, but with respect to that, if you had a nevus, you had that whole risk profile, and Dr. saying that here's your chance. At what level, how many of those things do you have to see, and at what level of risk are you at when you say, look, at this point, I'm not going to treat like it's melanoma because the risk is X, and that's a lower thing.
Yeah, this is another fantastic question. I was talking to Ali about this last night. If you talk to a bunch of ocular oncologists, you're going to get a different answer from each person as to what their threshold is. Some of it is a decision that's made joint with the patient as well, where we say, this is making me a bit uncomfortable. I have seen these characteristics. The lesion is growing. This makes me want to move forward. And I've had some patients that are like, I don't want to move forward, period. I don't want to move forward unless I know for sure, where you do a biopsy. I have some patients that are like, I don't like this risk and I want to move forward now, even though you're not concerned. So I think some of that is based in the conversation as well. All right. Thanks so much. So now we're going to move forward talking about treatment, local treatment of what's going on in the eye. And so we will start off with two presentations. First from Matt Studensky talking about plaque brachytherapy. Perfect. Talking about plaque brachytherapy, followed by a presentation on proton beam radiation. And then we'll have a quick few slides on the AURA trial, and we'll have a panel discussion. We would also like to let people know that there is an alternative session down the hall in the Arkin boardroom. That's a space for open discussion with a social worker. So if you have interest in that session, please, by all means, you can head down the hall and we will guide you to that room.
Okay, well, good morning, everyone. So my name's Matt, and I am one of the physicists here at Sylvester Comprehensive Cancer Center. So I've been doing these iPlex now since I've gotten to Miami, so almost 13 years. I planned hundreds and hundreds and hundreds of iPlex. So I'm sort of the guy behind the scenes that deals with all the radiation anytime you're going to get any type of radiation, be external beam or brachytherapy, there's a physicist that's in the background, making sure that everything is being done safely, being done appropriately, precisely, and accurately. So because I'm also an engineer, because I like teaching, I figure a little bit of basic radiation physics before we go into all the advances is always a good thing. So when we're talking about using radiation to treat cancer, the idea is that we need to have very high energy, right? Because we need to be able to cause damage on a cellular level. So when we're talking about electromagnetic radiation, which is one way we can do this, we have the spectrum. We've got photons bouncing around right now. That's visible light. That's down here, sort of in the middle of the spectrum. We need something way on this far side, something very high energy. And these are photons that originate either outside the nucleus or from inside the nucleus itself. So they're very high energy. We can also use different type of particles. We can use protons, electrons, alpha particles, other things that also have very high energy particles that can cause this damage. So the idea is that as this high energy enters the cells, you cause damage on the DNA. So this can be done directly. That can be damage to the DNA strand itself, or you can cause damage to water, which then ionizes, which also can cause damage to the DNA. But the point is, when there's damage on the DNA, the cell tries to repair itself. And if the damage is bad enough, the cell can't make that repair and it can die. And this is also more effective for cells that are dividing quickly. And that's what cancer cells do. They divide very quickly. And when this damage happens when the cell is dividing, then the cell can't repair itself, the cell dies, and we can hopefully eradicate the cancer. So that's really what we're trying to do with radiation. It also damages healthy cells, but again, these are not dividing as quickly. They're not quite as sensitive to the radiation as the cancer cells are. So we can preferentially try to deliver the dose to the cancer cells while avoiding all the healthy tissue. So we can really deliver this radiation in two separate ways. We can do external beam radiation therapy. So this is where we take particles, maybe a proton or an electron, and we use either a cyclotron or a linear accelerator to get them to this very high energy. And then we sort of rotate a gantry or something around the patient, and we can bring the radiation from the outside in and sort of concentrate it on top of the tumor while trying to avoid all of our normal structures. I'm not going to talk more than that because Dr. Dagan is going to talk about proton therapy. What I'm going to talk about is the other option, which is brachytherapy. So rather than treating from the outside in, we're sort of treating from the inside out. So with brachytherapy, the idea is to take a radioactive source and put it either inside or very close to the tumor. So sort of the result of that is if you see brachytherapy, which would be on the right side up there or your left, you see that treating from the inside out, you can really concentrate the dose inside the tumor. External beam, you can see the white line on your right side. You can see that because we have to bring the beams in coming from the outside, you sort of get a spread of lower dose, which sometimes isn't ideal. The problem with brachytherapy, though, is you have to be able to access the tumor. So this might be a surgical intervention or something else. So it can be a little bit more complex. And also with brachytherapy, you're limited on the size of tumors that we can treat. Now, that said, this is great for ocular melanomas because they're small tumors. They're relatively easily accessible. So brachytherapy is a very good way of getting the radiation into the tumors. So this is more of a chemistry thing, and I'm going to focus on eye-plaque brachytherapy specifically. So when we're talking about eye-plaque brachytherapy, a lot of times we're using iodine. So iodine is one of the elements on the periodic table. And again, there's other ones that we can use. Palladium's an option, but iodine tends to be one of the more typical ones, and I'll focus on that real quickly. But the point is when you have these elements, and you've probably all seen the periodic table, but as physicists, we can't be outdone by chemists. So we have our chart of the nuclides, right? So this is the periodic table on steroids. So what it's basically saying is, if you zoom in on this, is each element, right? It's an element because it has a certain number of protons, but it also has a number of neutrons in there. So that's where these different nuclides form, right? They have different number of neutrons, the same number of protons, but different neutrons. And that means the atom really isn't happy. It wants to come right down the middle of this chart here. That's where it's happy and stable. So we can, through different radioactive in nuclear accelerators and other things, we can create these artificially. And what happens is these unhappy atoms want to get rid of energy. And that's how we get radioactive decay. And that's how we create these brachytherapy sources. So you can see this is iodine 125. This is what we use. It's pretty stable, but it still likes to decay. It has a half-life. You might hear that term. What a half-life is basically over 60 days for iodine 125, that if you had 100 particles, after 60 days, you're only going to have 50. And then another 60 days, it's another half and half. And as those decay, they deposit energy. And you can see that here, this is iodine 125. It decays down to tellurium, and it has a gamma ray of an energy of about 35 keV. And that's what's actually right next to the tumor cells, and that's what is depositing the energy and causing the damage. So how do we do that? We have little seeds. So we take iodine 125, we cram it into some sort of capsule, and then we just need to get it next to the tumor. So specifically for eye plaques, the goal, again, we want to deliver a very high dose of radiation to the tumor, but we also want to spare everything else around it. So like Dr. Williams is talking about, we need to have imaging to do this. So we have our ultrasound, we have our fundus photos, and we can also use CT, or we can also use MRI to build a better picture of what's going on with the tumor itself. So you can see here the tumor in this image. And then the idea is we need to now get our radiation next to that tumor. So the way we do that is we put it into what's called a plaque. So we have two different styles of plaques. We have the COMS plaques, and this goes back to the old collaborative ocular melanoma study. These are, you can see that there's different sizes depending on the size of the tumor. They can go from larger to smaller. And we also have notched plaques that have a little notch at the bottom for a very posterior tumor that might be next to the optic nerve. And this allows us to get the plaque closer for these very posterior tumors. We also now have these eye physics plaques. The design is slightly different. They're still basically a gold material, but rather than the sources just sitting inside the plaque, they sit in little slots, which helps provide a little bit of collimation. It helps reduce the dose to the sclera. And these are all things that we're going to calculate when we generate an eye plaque treatment plan. So the reason we have this gold material is you can see on your left, if you don't have the gold material, you have radiation going in all directions. So these brachytherapy sources they emit radiation in every single direction. So by putting gold there, we can block any radiation from going the wrong direction. So we can focus everything into the eye, as you can see on the right side. So all the doses going into the eye, and we can spare everything else around it. So in terms of the treatment planning, and this is really where the advances are coming, is how we can now optimize and customize the plaque for every single patient. So we can take all the imaging that we have, we can take different planes, and we can build an actual model of the patient's eye and the tumor, and we can come up with this 3D picture of what's actually going on. And then we can say, okay, we need to put a plaque on top of the tumor. Where's the optic disc? Where's the macula? Where are these structures we want to spare in relationship to the tumor? And how can we get the dose into the tumor while sparing everything else? We can also use our fundus images. This helps us model the tumor. So we can now localize this a little bit better, again, in relationship to where all our critical structures are. So our optic disc, the macula, and again, spare those while getting the dose into the tumor. So again, we can now build a model. We can figure out where to put the plaque. We can do this in 3 dimensions. And then all we need to do is calculate the dose. So we usually want to get a dose of about 85 gray. We want to get that to the apex of the tumor. And then again, we want to keep the dose to all the other organs as low as possible. Here at Miami, we do about a 3-day implant. So the radiation will be delivered over the full 3 days. And we can then figure out the activity of the sources needed to deliver that dose over the course of 3 days. And you can see we can then look at the isodose distribution. So these lines show us where the dose is going to go inside the eye. And this again is helping us to conform the plan. And the way we sort of look at that is something called a dose area histogram. So the green and the brown are the tumor, and then everything else on the left side that you see are all the organs at risk. And the idea is this is showing the dose that a certain volume is getting. So the tumor and the margin, the green is the margin. So we also put a margin around our tumor just to account for any uncertainty. But the idea is to get the dose as high as possible to 100%, right? We want the whole tumor covered. And then all our organs at risk, we want those pushed way down to the left to almost get 0 dose. So when we're optimizing the plan, our goal as physicists and radiation oncologists and everyone is to separate those 2 lines to get the tumor as covered as possible with all the organs at risk being as low as possible. And the way we do that is by just playing around with the sources in the plaque. We can have higher or lower activity sources. We can move for a posterior tumor. We can then reduce those maybe posterior activity. And again, the idea being get the dose to the tumor while sparing everything else around it. And that's really all I have for the eye plaque side of things. And then I'll let Dr. Dagan talk about the proton therapy.
If you have any questions during these presentations, write them down and then raise your hand from the panel discussion and we will definitely get to those questions.
Well, thank you all for having me. I'll be pulling up my slides. I'm going to start with two embarrassing confessions. One is that I spend most of my time trying to avoid treating the eye as a head and neck radiation oncologist, and especially at a proton center where over the years, many patients are referred because of periocular, skull base, or sinonasal cancers. My entire professional focus has been to avoid treating the eye with radiotherapy. So it seems kind of embarrassing that I'm going to tell you all about how in half my life now I direct high dose radiation to the eye with proton beams. The second is that, second confession is that ophthalmology was my weakest course in medical school. So it seems a little bit like Coles to Newcastle here to be talking about treating eye cancers at a place that's taught most of us in the medical community what it really takes to treat eye cancers, which is a phenomenal team built with experts and built around patient-focused care. So most of us actually spend our professional lives trying to emulate what our colleagues at Bascom Palmer have done so well over many decades. So with that, I'll give you a little bit of history about our center. The University of Florida Proton Therapy Institute was the first particle therapy treatment center in the southeastern United States. We were number 5 overall in the country. At the time of our development, this was really a nascent emerging technology in scale. There had been a handful of centers around the world, most notably in the US at the Massachusetts General Hospital, but really pretty rare kind of treatment modality for all kinds of cancers. Interestingly, there were more proton centers around the world at the time treating only eye tumors because you didn't need as large or energetic a proton therapy to reach more superficial targets. So by the time we got started, there were already a number of documented excellent outcome series treating patients with proton therapy for eye melanomas, but that certainly was not our focus in the beginning. We broke ground in 2003. Our cyclotron showed up 2 years later. That's the particle accelerator that you see on this bottom image. That is a engineer, so you can who's about 6 feet tall, so you can see the scale of this machine. It's an amazing piece of technology. It took some time after that, almost a year and a half, to complete our first gantry room, and it was shortly after that that we started treating patients in 2006 with our second and third treatment rooms coming online the following year. You'll notice that there's a 3-year gap to our next development when we finally opened up our eyeline room, which took a lot of extra effort. The company IBA that developed that commercialized our system and still helps run our operation had not built one of these eyeline rooms before. So we were their first journey into it, and true to form, it took about 3 years behind schedule to actually become operational. An additional 2 years before we treated our first eye patient in 2012. And it was right around that time that my boss said, "Roy, I need you to do this." And I think I told some of you all that my first response to her was no, which was the first time I'd ever told her no for anything. So she did this very sly thing that I think is a very excellent skill as a leader. You just start the conversation over as if the first time it didn't happen. So a week later, she came to me and said, "Roy, I need you to take care of the eye patients for us." And I thought, well, if I tell her no again, we're just going to do this next week and next week and next week. So I told her yes, and I treated my first patient in 2013 when my predecessor, Dr. Maliappa, left. In 2019, we opened up an expansion, our second accelerator, this time a synchrotron, powering our Proteus One standalone unit, which is, by many measures, the latest and greatest in proton technology. And as of this year, we'll complete patient treatment number 300 on our eyeline in a program that's really, really taken off in the last couple of years. You all heard a lot about different radiation technologies from the previous speaker. And the whole premise of proton therapy is really something that it was an overarching theme of his talk. It's how do we get more dose in the target? How do we get less dose in the non-target tissues? So what you're seeing here is a depth dose profile of an X-ray beam, which is the most common way we treat cancers with external radiation in orange, and then what a profile looks like with a proton beam. So essentially you're eliminating more than half of the unnecessary dose on the entry side, but all of the dose on the exit side, because particle beams interact with matter very differently than X-rays or gamma rays from brachytherapy sources. They have what we call stopping power. That means beyond a certain range, there's no exit dose, there's no further spillage into the normal healthy tissue. And so the whole premise of proton therapy is to harness these advantages to improve the therapeutic ratio, the chances of helping a patient versus the chances of hurting them with a treatment. And just like my colleague described earlier, as they try and do with brachytherapy, our whole point is to harness this and get, again, as much of the dose in the normal healthy tissues and avoid in the tumor and avoid the normal healthy tissues. There have been a number of comparisons that look at these two different modalities, radiation modalities, in treating uveal melanomas. And probably the most sophisticated analysis came from our colleagues at MGH, Alexei Timarov, who's a medical physicist, who showed that, in some situations there were advantages, in others there may not be advantages or even disadvantages to proton therapy over brachytherapy. So I'm not here to advocate for technology. The reality is we're all going to have hopefully better tools in the future. But one of the things that you just simply cannot get around is that with brachytherapy, there's this inverse square relationship to the dose relative to the distance from the source. And so what you're seeing here in these dose volume histograms here is that with a plaque, you end up with a lot more high dose going to the tissues than with a proton therapy beam. And you can see here that the minimum depth that we would prescribe to with a plaque would be 5 millimeters from the surface of the plaque. And so what that means in an inverse squared relationship is that the dose at the surface is 25-fold. And that was evident in the previous presentation where you have these very hot areas right next to the plaque. Now that may be advantageous for tumor destruction, but the reality is that that's right where the retinal tissues are, and even more problematic, the retinal pigmented epithelium, which is so critical for survival of this tissue. So we've done, we've made some efforts to compare these modalities, and there's this one well-known study. It's a very small randomized trial where half the patients got charged particle therapy using a helium beam and the other half got brachytherapy. And, there were advantages, at least in this study. But again, I'm not here to advocate for one technology over the other. I think brachytherapy is an excellent treatment for many patients, will be the only available treatment. And I think that many people should continue to get brachytherapy. But the reality is that the outcomes with proton therapy or with charged particle therapy are excellent. And for those that either can't get brachytherapy or live close to a proton therapy center, maybe to their advantage. We've done our best to compare this. We worked mainly with the Mayo Clinic group in Jacksonville. Jim Bowling, who I worked with for many years, looked at our initial outcomes with them, compared them to his outcomes with brachy patients. And I think there are some important lessons as we look at this analysis. Number one was that the rate of double vision, at least in transient way, was much lower after proton beam therapy than a radioactive implant. And this makes sense, and especially in the way that we've done it with the Mayo Clinic team, where in order to insert the markers that I'll show you in a moment to help guide the treatment, we don't actually have to release any of the muscles that control eye movements, as is often done with implants. And so sometimes when you all get out of that surgery, you wake up with a little misalignment of your eyes, and that leads to double vision, which is almost never the case when we're treating with proton therapy. And you can see the rate of muscle reimplantation here, where we only had to do it in one patient who was treated with proton beam at the time of this analysis. Enucleation control rates were excellent, about the same. One of the major disadvantages, though, of the proton beam therapy is because we enter through the front of the eye, there are more effects on the superficial tissues, including the eyelids and the tear drainage system. And so many of our patients were at much higher risk for epiphora or tearing compared to patients who got implants. And then finally, although it wasn't, it was a very minor difference numerically, and it did reach statistical significance. Especially now, our colleague, Dr. Armand Mashiaki, firmly believes that there are less negative effects on the retinal tissues and specifically the macula when we treat with proton beam therapy compared to the implant. So how do we do this? It starts with collaboration, and this is primarily driven by our ocular oncology colleagues, where they provide us all of the imaging, all of the measurements that we need to model the eye. It culminates in an operation where 3 to 4, most often 4 of these tiny tantalum markers are placed on the surface of the eye, and a whole bunch of detailed measurements that our colleagues provide us. Measurements of distances in submillimeter levels from markers to normal anatomy, and markers to tumor, and a map of the back of the eye in these markers in relation to it that all feeds into a model that we use to prepare the treatment even before patients arrive to the center. When they come to the center, our first order of business is to help them hold still. This is now a collaborative journey between you all and us. And one of the things I tell all of our patients is that we demand more of you than 99% of the people that we treat in our building, because there's an active component. You are the ones holding your eyes very still so that we can deliver what's arguably the most precise radiation beam in the world. We help you with devices that help your head hold still, but you still have to find a gaze fixation light to help direct the eye into the correct position. The treatment is done with these eyelid retractors, which is admittedly the most obnoxious thing I do to you all, but actually not, it's well tolerated because we numb up the eye, we lubricate the eye, and also keeps us on the clock to get this over with as quickly as possible. We've used increasingly imaging to help direct the treatment beyond just the ultrasounds, fundus images, and OCT scans, where high definition MRIs now help guide the treatments in a way that adds a lot of confidence, that we're using the best model of the eye, the best model of the tumor to direct the treatment. And ultimately, our goal is to get 6,000 centigrade, that's our radiation unit, into this tumor over 4 treatments in a homogeneous way and protect as much of the healthy eye as possible. And we can see that whether we overlay the dose onto the image of the back of the eye, onto our model in our treatment planning system, or the imaging to help give us confidence to this. Our goal with you all is to find that gazing light, position the eye, and help and hold it still at a submillimeter level. And this is, again, all done by directing the treatment to these small markers shown on the surface of the eye. So when we look at it on our imaging and our treatment platform, we can see the markers in the dark here perfectly overlaying their planned position in these pink ovals, with a residual error discrepancy between where we're supposed to be and where you all are holding still that is usually something like this, 0.1 millimeters. The actual treatments are monitored in real time. This is a video of a treatment where once we've aligned to markers, I've outlined surface anatomy here, and we can keep close watch of that to make sure everybody's holding still. From the moment I hit play, we start treating this patient. You can see reflexive attempts at blinking, but the eye never really deviates from its planned position. At 15 seconds into it, told him, treatment's over. You can look straight ahead and relax. And we get the patient out of all those devices. This is a brief video. Nobody likes to watch it for more than 15 seconds. So admittedly not that fair. It's more likely that it'll take 25 to 45 seconds to deliver this treatment each of these 4 treatment days. So where is this going? Like I said, we've treated about 300 patients with this technology. It's a wonderful system. It is a very reliable, very effective, very efficient way of taking care of patients with this condition. But the reality is that very few, if any, centers are going to put the resources in place that it takes to treat only one condition with a proton beam. So we're all thinking about ways to move this to our more workhorse machines, our gantries that can treat tumors all over the body. In our institution, the plan over the next few years is to convert the treatments to our Proteus One system. We're going to have all kinds of fancy, sophisticated ways to track the eye position, since that technology has evolved far beyond our touch screen and drawing. And we're all very excited about what this technology will have to offer. But I think what's even more exciting is new tools to use radiation in very fundamentally different ways. And one of the emerging technologies here is something called flash radiation, where treatments aren't delivered over minutes or seconds, they're delivered in microseconds, meaning literally a flash. And it turns out there's a different biology associated with this. The high dose rate will create less reactive oxygen species that are more implicated in damaging the retinal tissues. We've seen this report just last year in Nature Science Journal, which showed that this principle may in fact be true, that we can target tumors while protecting normal healthy tissues in a retinal pigmented epithelial model. And I think this is very exciting. There's a lot of technological hurdles that we have to overcome to implement this in the clinic. We're just now seeing our first clinical trials. There are also a whole bunch of biologic questions that we still need to answer, and whether this will be an effective and safe way to treat this condition. But to me, this is the best place to go in curative clinical medicine, because it's challenging, but you all have been amazing to be able to hold these positions, keep your gaze fixed for 15 to 30 seconds or 45 seconds. But what if we could do it like that, right? How much easier would it be for you all than holding still and for that long? And I think this is, to me, a very good practical indication, considering that we have to target very sensitive retinal tissues when we treat this condition. So with that, I want to give thanks to a bunch of wonderful collaborators and colleagues. Dr. Mashiaki, who has been a fantastic partner at Mayo Clinic. He refers about 90% of the patients who treat our center. His predecessor, Jim Bowling, who trained Armand at Wills, was one of the saddest days of my professional career when he retired. But then when he introduced me to Armand, it quickly became one of the best days of my professional career. Some of you in the room know Dr. Kim and Dr. Wu at Mass Eye and Ear. They've been wonderful new partners as their technology is evolving and hopefully will upgrade in the next few years. In the meantime, they're referring patients to our Jacksonville site. Dr. Ibrahim Abid, who's a retina specialist in Gainesville, who is one of our newer partners and wonderful colleagues. And really have to give thanks to our physics staff, Maria Mamalui, Twyla Willoughby, who are just fantastic. We can't do any of this without them. Lisa Ward, who is so critical in coordinating care between the different referring centers and helping patients navigate this process. And my colleague, Dr. Jean-Baptiste, who's a recent addition to my team. But mostly I want to thank you all, our patients, our families, caretakers. You all remain, our most vital source for why we do what we do, and constant reminder of how important the work is, how meaningful it is, and especially in this indication where it is a partnership. You all make it happen. Without you, I could not deliver this safely or effectively, and I'm grateful that you entrust us with your care. Thank you.
So we've now heard about two of our most tried and true treatment approaches. Brian, Marr, Colleen, Seville, if you'd like to come on up. We are going to talk a little bit about some of the newer technologies and also go over a couple of cases and kind of open it up for discussion as well. So Dr. Marr is visiting us from Columbia, New York, not the country. I know we have a Colombian patient here. And he's going to talk a little bit about belzupacap sarotalacan, which is in clinical trials.
Don't you love drug names? Like, doesn't that just roll off your tongue? So Belzar, I'll call it for short, but I actually knew it when it was AU011, which is my favorite name for it. But this is a neat story and one that kind of I have experienced. I first met the founder and the clinical scientist from the NIH when I was at Sloan, and the head of the hospital called me and said, "Hey, I want you to meet a couple people." And this lady and gentleman came in. They said that they were working on a drug to treat primary uveal melanoma. I'm like, what? I mean, no one ever in industry has come to treat primary uveal melanoma. So I was very interested. And I was like, oh, this is going to be exciting. We're going to have a new tool to use for uveal melanoma. And this was about 10 years ago. And so basically it's been I was the PI of the phase 1 trial, and the drug itself, which I'll tell you a little bit about, has evolved, and now we're in phase 3 trials. So it's been about 9 years to take an idea from 2 people to make it through into industry. And so I'll tell you where we are, what we started with, and what's going on currently. So basically, Belzar is a new first-in-class type drug. It took a viral-like particle. And so John Schiller's research was on HPV virus. And he found that HPV virus has a mechanism that binds to cells to get the virus into the cell. And that's a similar mechanism that cancer cells use to bind to cells to stay in the body. And so this viral particle he took, isolated, replicated it, and then attached a payload, or like a bomb, and it's detonated by light. So it's a photoreactive particle. And so they put those 2 together, and this was the idea that they could deliver a targeted therapy to actually cancer-specific cells. And so this was able to be made, and this is kind of the structure of the molecule you'll see here. These are all viral capsids, and then the little orange dots are the little bombs, or the little photodynamic dyes. And so here's a piece of it, and you can see the viral particle plus the photodynamic dye. So the idea in ophthalmology is we were able to treat different things like age-related macular degeneration and other intraocular lesions by using light associated with a dye that we injected locally. And this was a way to treat macular degeneration in the 90s and early 2000s. And it was like the combination of these 2 photodynamic, meaning using light to activate this compound to cause oxygen-free radicals, to cause a chemical assault on tumors and blood vessels and things like that. Well, this uses the same properties, but instead of going after blood vessels and benign things, it goes after tumors. And so here's kind of a cartoon of how it acts. These heparin sulfate proteoglycans, these are these proteins that the viral particle targets, and that those are what cancer cells express. And it binds to that. Once it's bound, then you shine a light on it, and it detonates, or actually causes this chemical reaction that causes these oxygen-free radicals. That breaks up the cell physically and also creates an immune response where the body is activated by looking at these foreign proteins and has a response. So we've went through phase 1 dose escalation and safety, phase 2 with some of the efficacy, and they changed the way that from giving the injection directly into the eye to giving the injection into the suprachoroidal space. So what is that? That's the layer between underneath the retina where the tumor actually grows closer to the choroid. And that was an attempt to increase its efficacy and its bioavailability. So what is the compass? So the phase 3 trial is now looking at outcomes and for approval. And it's taking a very specific lesion that people get, and they're called melanocytic indeterminate lesions or small melanomas. And these are some of the cases that Basil presented where, you're kind of on the borderline. This is a really early melanoma. Do we wait for it? Do we watch it grow? Do we biopsy it? Do we treat it? And this is one of the ways to treat it without causing visual damage. Because unlike radiation and unlike thermal laser and unlike protons, the side effects of this treatment is significantly less because it uses just infrared light to activate the drug on a molecular level. So to qualify for this, you have to have a small melanoma, and there's size requirements. It has to be under 12 millimeters in basal diameter and under 3.5 millimeters in thickness. It has to be kind of in the back of the eye where you can see it, because you can't get the laser way out to the corners, or you can't get pictures out in that area to take pictures to document whether it's growing or not. And it has to have grown or had documented growth, because one of these things that this drug does is it doesn't make the tumor disappears, but it may just stop it from growing. And so that is one of the endpoints that the FDA wanted to see to get this passed. And so we're almost towards the end of the accrual. And in the phase 2 studies, I can't say much about the phase 3 at this point until it's finished, but in the phase 2 studies, about 80+% of people would have a response that, first of all, didn't decrease their vision, and second of all, didn't have tumor progression. And so that's kind of where we are there. It wasn't perfect. It wasn't as effective as brachytherapy or proton, but 93% of the patients retained their current vision, or it improved. So really, this study and drug, if it gets approved in the future, does offer a vision-friendly treatment for small lesions. And so once it's approved, we may see further indications, and it's also being used for metastatic lesions from other cancers. So breast metastasis to the eye and lung metastasis to the eye, it also will bind to that cancer as well as melanoma. And it's also being used in bladder cancer, where it's irrigated within the bladder. They illuminate it with a light through a catheter, and that's shown very good results. So it's something to keep an eye on. It's getting very close. It's been 9 years in the making, and hopefully it will be a tool for people with small melanomas in the future. Thanks.
All right, great. So now we have two of our most tried and true treatment approaches. We have something that's in clinical trials and potentially exciting, as we haven't talked a lot about the side effect profile of radiation, but we know, and many of you know, whether you're getting injections or not, that radiation effects are real. And so I want to kind of go through a couple of cases and talk a little bit about how we would approach them from a treatment perspective. And we can go from there. Alex, can you pull up my slides? So, Dr. Sabula, if you would like to introduce yourself as well. And just so you all know, when I was a medical student coming down here to do research for the first time, Dr. Sabula was a retina fellow, and I wrote my first paper with her. So I'm very appreciative of her guidance over the many, many years. Even though neither one of us look old enough for it to have been many, many years. It's on. It looks like it's on. There it is.
Oh, it's on. Thanks, Alex. So yeah, it's nice to be back at Bascom Palmer. I did my ophthalmology training here, and that's where I met Basil Williams. So it really means so much to be able to come here and participate in this great conference. So yeah, I've been a professor at Ohio State University. I'm originally from Ohio. And it was fun being in Miami for a while, but I'm glad I could be back in Ohio. So it's just a pleasure. I'm also a clinician scientist, so I take care of patients. I do a lot of research, both with a geneticist colleague, and then also have a kind of a retina research lab. We're talking about trying to preserve vision. And then, we educate a lot of students. So we love working with our trainees and training the next generation of practitioners. So thanks again for having me.
Excellent. So we talked about Belsar already. So we're going to start with a case. So here is a melanoma that is fairly large to the point where it's hard to see where the nerve is. And sometimes we have patients that come in and I say acute noticing of a chronic problem because I know that this did not pop up overnight, but sometimes people don't notice it. So Brian or Colleen, you see this, the patient comes into you, they noticed just a few days ago that their vision changed. What conversation are you having with the patient about treatment? How do you approach this?
So first of all, I'd like to kind of give it a history and see what they've experienced. If they experienced nothing, then, basically I'll have to give them a diagnosis. But sometimes patients will stop at a primary care provider, go to a optometrist, go to a primary ophthalmologist, then go to a retina specialist, and then come to me. And so sometimes they kind of have an idea what's going on. But if not, then I say that there's something in the eye that it looks like it's pretty classic for a melanoma. And they're like, how do you know that? And I kind of use the analogy because I'm from New York. If you go out on the street and you see a yellow car with a light on the top that has numbers on it and has checkers, you kind of know what it is by looking at it. And the same thing is it's a taxi, right? So if we see a big, large pigmented lesion that has subretinal fluid, orange pigment is just kind of distorting the anatomy, then, all of us in this profession are very good at clinically diagnosing that, especially in a case like this. So then I explained the treatment options, and we had a whole list of those, review, and then see where people want to go with it.
Excellent. So this is a fairly large lesion that is overlying the nerve. The vision is already quite limited. Dr. Sabila?
Yeah, so I think, part of it is assessing the whole situation and the patient as well, and just having a conversation. So when it's a really large lesion, we kind of have to think about, well, this may be so large that, the eye will not do well with that, may have a higher chance of recurrence if we try radiation-based treatments, may lose all their vision anyway. Especially we're not seeing the nerve, so that's totally covered. So I think, that's something where I think, obviously, like one option may be enucleation, which is removal of the eye. Another thought is some sort of radiation-based treatment, so like brachytherapy. It's pretty hard to treat with brachytherapy when you can't see the nerve at all. So it's kind of going around maybe too many clock hours for that. Proton beam might be another option if that's accessible, because they can sometimes treat tumors around the nerve more effectively. But unfortunately, the visual prognosis is not going to be good over time. So I would definitely lay out all those things with the patient, and also kind of assess, what's their physical condition and what's their family situation and what kind of support they have, and what are their goals. The most important thing is to talk with the patient and see what is the right treatment for them. And sometimes that may take some time, like they might want to talk it over with their family first, and those kind of things. So it's a very difficult kind of decision. So I would leave it at that, I guess.
So I like to kind of break it down into really simple terms. I'd like to say, well, my first concern if I am diagnosed with cancer is, well, am I going to live or not? Right. And is there something that I can do to change that? Right. And so we address those risks and what the possibilities are that. And that puts us in one category. And then, am I going to be affected by this? Am I going to lose vision? Is it going to affect the way I look? And so I address that, and we say, all right, well, what's the safest thing that we can do to, not make me die from this? And how much can I save in that part? And is that important to me? And so I think those are the kind of things that I address. And that mechanism is the way I go about finding the right treatment for the patient. And if you know all those different risks and benefits and treatment modalities, you can make a pretty easy decision.
So I think one of the most helpful things about this conversation, obviously there are a number of patients in the audience who have had enucleations, even though we're talking about radiation and novel ways that we can work with plaques to kind of customize them and potential flash therapy, to reduce risk in the Belsar trial. Enucleation is still a completely appropriate option in certain situations. So I don't want anyone thinking that they got the wrong thing or something like that. That is the right thing in certain situations. And so depending on what things are like, there's going to be a range of potential treatment options. So I want to share another case of quite a large tumor here as well. And the first thing I want to bring up is that this was a young patient in her 20s. We talked earlier about ocular melanocytosis. This patient had that, but she was never diagnosed and she never knew that. And so even though some of those features were noted, it would have been very helpful to her to have routine exams. And so that's the first thing I want to point out. The second thing I want to point out is this is a very large tumor, but let's say this is the patient's only eye, or let's say that they really want to do everything they can to save this eye and they don't want to have it removed. When we think about radiation in this situation, Matt, I would love for you to talk just briefly about when a tumor is very large and you're thinking about a plaque and you're thinking about how much damage that might do to the sclera. How do we approach that for high doses to the sclera, and how do we think about our radiation dosage to the apex, et cetera?
Well, two things. Remember, there's two different types of plaque designs, right? We have the comms plaques and we have the eye physics plaques. So one of the things that the eye physics plaques has is it has that slotted design where the source actually sits basically within two gold notches. So what that does is where sort of the rays of radiation will intersect is going to be beyond the sclera. So that helps us reduce the sclera dose a little bit. And another thing that we've started doing with these tumors is actually reducing the dose. So typically we would want to get 85 gray to the apex of the tumor. But as Dr. Dagan said, the problem with brachytherapy is as you push dose further and further away from the source, it gets much, much hotter close to the source. And what's right there is your sclera. So what we've done is, knowing that we're going to have a very high dose near the sclera anyway, is reduce the dose that we go to the apex, maybe to 75 or 70 gray, and try to reduce that sclera dose just to help reduce some of the toxicity.
So this is we had our International Society of Ocular Oncology conference in Rio de Janeiro a couple of weeks ago. And one of the discussions, that's also a good option for the next meeting. And one of the discussion points that we had there was dose reduction. We've been doing 85 gray with plaques for a long time, and it does really well of killing the tumor, but it also affects some of the healthy tissues. And so can we decrease that dose to continue killing the tumor, but also reduce the radiation-related side effects? Do any of our ocular oncologists want to have any comments about dose reduction, or how they think about it, or what that might look like in terms of a trial, or how do we evaluate that?
I could be biased. So if you really look into it, the dose originally that was used like in Stollard's day, where they like nearly 100 years ago, was significantly higher, and the isotopes were different. And then from that, for the COM study, there was an arbitrary that dose looks good decision that was made for the 85 gray. And that was an empiric guess on the people who constructed the dosing of it, and we've followed it ever since. And I think that it really begs the science to kind of evaluate lower doses. You don't want to cause more recurrences and increase metastasis. So everyone's been very reluctant to explore that because we don't want to cause any harm. But I think that, there's good evidence now in some isolated studies that a lower dose will still work. And how much, we don't know the details, but I think it's something really that I'm very interested in. I think we're going to see a little bit of a dose drop if we can get together and get good data for that.
Yeah, I'll just add real quick that, with smaller tumors, I think we've already seen that, because in the COMS study, they were treating, even if a tumor was say 3 millimeters thick, they would still treat it to 5 millimeters. just routinely. And so now I think we're treating more to the actual, height, more commonly. So I think we've already seen improvements in that, and that people are doing very well with that. But we do have such good, local control outcomes with our current 85 grade to the apex. So I think we are a little bit, nervous to change it too much, but I think you will, like you said, see more variations in that.
And the custom plaques that we were talking about really have made a difference. So you can really kind of do some work with that, and the physicists should be commended for all the advancements in that.
Absolutely. John, and then Ed.
Is there options for combination therapy that is to say you use one perhaps the low dosage steroid therapy to knock it down, follow with the proton therapy or start? Belsar comes along and move to something else, to contain it, stop its growth, and follow with something that.
Who wants to take this question?
I like that idea.
Well, it's
yeah.
So there's stuff coming, and I don't know if we're going to talk about some of the neoadjuvant.
We will in a
Right.
different.
So there are things that we are looking for to do exactly what you're talking about, is to use one modality to get it smaller, so the radiation dose that we'll do will be less. And so that's in the mix, and we'll probably hear about it today.
I think what's really exciting is like to add the genetics, right? I think to me, that's the low hanging fruit. There are logistical challenges because of the timing of biopsy, when you get those results, and ultimately when you have to prescribe the dose. But as we've now discriminated this into, it's not one disease, right? So why are we using one dose? And it's quite possible, I think, to me, the cognitive ease is that less aggressive tumors may need less dose.
So Ed, right before we come to you, a lot of our answers are going to be, we don't really know. Which is helpful though, because this is a discussion that is stimulating and kind of helps push us. Some of these things we're already looking at. I know Duke and the team in Memphis has decreased their radiation dose already, and they have pretty good results. But in general, as a field in oncology, we try not to just completely experiment, especially when we have something that is going pretty well. So we're trying to figure out how to approach these fantastic questions with a true scientific approach and make sure that we have less side effects while not compromising the overall effect.
So do animals like chimpanzees or pigs or something else, do they develop ocular melanoma? And with some of these trials, that's been done on animals. Like, I don't get that done.
The question is, what is the animal model for uveal melanoma, and how can you assess radiation according to that?
We like treating rats and mice, but mostly for normal tissue effects. I'm not aware of a murine or any other animal model for melanoma.
Go ahead. Yeah.
So uveal melanoma cells in general, to culture, to reproduce, and to replicate are notoriously hard to do. And there's, cell lines to experiment. There's only like a handful of commercially available cell lines that you can work with. And, the question are at this point, do they really represent real melanoma cells or not? Because they've been, recapitulated over the years. So historically, it's been very hard. There's no animal model. And I think size kind of matters in this, because like a rat plaque would be very hard to construct. And, there's, people that don't like working on pigs and monkeys and things like that. And so, plus the fact there's no good animal model for it. So that's one of the reasons we haven't done it in that respect.
So I would add, so dogs do get uveal melanoma, but it's not used that much. And there haven't been like radiation studies with dogs, but I know like at Ohio State, there's a veterinarian who works with, dogs with melanoma in the eye. So, I mean, I think there are, but it's not like a widely used model. Yeah. I think
it's not a widely used model. And I would, for the government is already trying to reduce how much animal studies we're doing.
Correct.
And we as a society are very dog friendly.
Yeah.
That would not be viewed favorably.
And then at the Brazil meeting, at the ISOO meeting, there was somebody who was looking at a new model called a tree shrew.
Yes.
So it's like a super tiny primate that looks kind of like what a squirrel maybe. So it's something that may, have some advantages to being kind of similar to human retinas, and especially seeing how we can try to treat the eye and look at radiation retinopathy and how can we better treat that. Because we really, it would be nice to have a model to study that.
Oh, we'd probably treat their whole brain in addition to their.
They're too cute though.
Next case, we have a lesion that's right up against the nerve, but it's fairly small here. When you think about this case, how do you decide plaque, proton, benefits? What do you think?
I've been talking too much. Go ahead.
Okay. Yeah. So, we have, right now we have plaque brachytherapy at our center. So, it's convenient to do brachytherapy for patients. They don't have to travel somewhere else. Currently I'd have to refer them to another center if we want to do protons. So I think, often I would mention the proton beam as an option, but again, it would be a lot more travel and difficulty for the patient. I think we did get a proton beam facility at our center, but it's not set up for eye treatment. Like, you kind of mentioned, it really requires some special equipment with that. So maybe in the future we'll do that. But I think plaque brachytherapy certainly is a good option for this tumor.
So, Roy, let's say this patient gets referred to you and they're going to have proton beam. Actually, this patient is in the process of getting referred to. Let's say that's the scenario. What conversation are you having about vision, efficacy, etc.?
Well, we go back to the beginning. My goal is not to undo the good work my colleagues have done, but it's important that that we re-engage with the patient to understand goals of care, make sure that we're prioritizing their goals and not ours. So this patient, may have a very small lesion. It may be subtle growth. There may be eligible for the ORA study. And if their priority is vision preservation, I may be going back to these options and saying, well, have we fully explored those at the risk of destroying the referral stream? But otherwise, it's, assuming we're moving forward with treatment, it's making sure that we have a full understanding of the goals of care. That number one, our goal is to destroy this tumor and not leave, or to minimize the chance rather that there'd be recurrence, progression, and ultimately metastases from residual disease in the eye. Eye preservation is our second goal, and that's got to be consistent with the patient's goal, because in reality, some of you all rather are going to prioritize, get this thing out of me. And if the vision prognosis is very poor, if the function is already compromised, and if that's your top goal, then I'm going back to my referring doctor and say, look, I think this patient may actually be better off with enucleation and prosthesis, because that's more consistent with their goals. But assuming their goal is to kill the tumor, save the eye, and hope to preserve vision, then we move forward. But in reality, I set up the expectation that one day you will be blind in this eye, and that having cared for many hundreds of you all, you will be okay. You will function and do everything that you want to do, that you've been doing. There's been 3 exceptions in my practice. Those are 3 airline pilots, and I think we can all agree they probably shouldn't be flying with one eye. But for everybody else, you will get to enjoy all the things you did before with some adjustment period. And if we're meeting on common ground, it's not a difficult thing to move forward together with proton beam therapy. The rest of the discussion is walking them through what the process will be like to head off any trouble related to anxiety, claustrophobia, or medical conditions that might prevent them from their aspect of the technical component of the treatment.
And that is a completely honest answer, because we did refer a patient for a proton beam with a lesion near the nerve. They had an extensive conversation with the patient, and ultimately the decision from everyone involved was to move forward with enucleation, which we ended up doing this week. So it is a genuine conversation of kind of laying out the pros and cons up front and then deciding together what's the right move after everyone has an understanding.
Can I do one other comment just along those lines? When a patient's in a chair and they have to make this decision to keep an eye or not to keep an eye, and let's say the vision's going to be bad, what's involved with keeping the eye is it requires a lot of doctor's visits, managements of complications, a lot of time, travel, money. So sometimes if the visual result's going to be the same, the patient's not thinking, oh, to preserve this eye because it sounds like I want to do this, I'm going to have to waste like a month of my life just seeing a doctor to do that. And, some people don't want to do that. Some people it's totally worth it. But those are kind of the things that you should discuss in making those decisions because, if I'm not going to see out of it and I don't want to be bothered, it's a lot easier to just have it done. And the recurrence rate is 0 if you don't have it there. So it's a great thing to do. And we all get attached to these things, literally. But sometimes it's the best decision.
I'll just also add on to that. I think it's so impressive just seeing somebody, it's so hard in the beginning when you have to think about losing an eye. But then, once you're through it, people do amazingly well and you really get your life back rapidly. And like you said, it's just, you don't have all those, appointments and injections and you just stay away from the doctor a little bit more. And I think people really do, like you mentioned, get back into the things that they were doing, but, people are doing before. And many times, once you have the prosthesis, a lot of times it's really hard to tell, like, which is the eye. And I might look at my notes, like, which one's the eye? So it's pretty impressive. And then also people are, expressing themselves through their prosthesis. So sometimes, we have people who really have a really cool prosthesis that does not match their other eye. It has like a music symbol or like, really cool colors. And I have a great patient who she works with children with disabilities. And so she wanted to show that she has this disability. And so she has a cool prosthesis that she got specially designed. And then she had a contest for her students to go ahead and draw the prosthesis design. And so then they had a winner and then she got that made. So I think it's such a cool thing. So
That's
yeah,
fantastic.
really cool.
I love it. So I want to share one more case, which actually goes over the lines of this discussion. So this is a patient that was treated in 2011, has a well-treated tumor here, felt pretty comfortable, and then kind of didn't come back for a little while. Life got busy, and then they came back some years later, and now the lesion looks like this. So you can see it's grown, and this is one of those rare cases where you do have recurrence. One thing that you can all see already is if you look in the first picture, you can see the blood vessels kind of throughout the entire eye. In the second picture, you don't see those blood vessels very well in the upper part of the eye or in the right side of the photo, which means that the initial radiation treatment has already knocked out some of those blood vessels. So now we have an eye where the blood vessels aren't working very well, and they have a recurrence here. So we just had the conversation about what are the goals of therapy and kind of how do you navigate that based on vision. We ended up having this conversation. The patient really wanted to keep the eye, and so they ended up getting repeat radiation. And the tumor is dead, completely flat. They kept the eye. If you look at the blood vessels now, you can see even more that the blood vessels are pretty significantly affected. So there is almost no vision in this eye. From the radiation perspective, and then we'll kind of go from the doctor-patient conversation perspective, when you're performing radiation on an area that's been previously treated, and you're thinking about radiation damage now to the retina, what that means from radiation retinopathy, vision, sometimes even pain. How do you think about that in the conversation with the patient?
Well, this question comes up often in broader contexts, for irradiation, because there are actually a number of indications in the head and neck space, which is where I spend most of my practice. And for the overwhelming majority of my career, I've been a reluctant re-irradiator because the outcomes are generally not well, and they're not great. A third of the time it helps, a third of the time wouldn't have mattered, tumor progresses or spreads, and then a third of the time it's devastating injury from cumulative effects of radiation. That said, there's two well-known, well-documented series, one from our Mass Eye and Ear colleagues, another one from Germany, documenting actually excellent results with redo radiation with proton beam therapy. Obviously, brachytherapy is an option. And so I think this, again, comes down to what are this patient's goals? What are their priorities? And we're better off listening than talking in these conversations. And by the time they get to me, the priority is I would like to save my eye. Otherwise, Dr. Williams or his colleagues would have removed it. But at that point, given the excellent results from Mass Eye and Ear,
our current, growing experience with it, I do offer to them with the understanding that they're almost certainly going to go blind and that the chances of success are lower. The chances of enucleation are going to be higher ultimately than in the upfront setting.
Any other comments?
So I've had the opportunity of being at a referral center to treat a lot of outside or other physicians' recurrences. And I was trying to publish that, but unfortunately, we didn't do it. But 86% of the time we could salvage a recurrence in an eye, right, without causing the eye to be removed. And that was through a series of repeat radiation, whether it's plaque brachytherapy or a proton, TTT or laser, thermal laser, combined even with photodynamic therapy. And through those media, I think 86% of the time, depending on where the recurrence is, how big the recurrence is, it's the eye is salvageable and the vision's dependent on its location.
Yeah. So I know there's at least a couple people that we had the conversation last night at dinner about TTT, so that can come into play in some of these situations. I want to share one last case, and then we can move on to the next session. So this is a little bit of a challenging case. So this is a patient where you can see in the bottom part of the iris is pretty brown. And this ultrasound is showing the area inferior to the iris. So in the area that the eyelid is partially covering. And so you can see here, and there's some pigment all along the surface of the iris. So this actually covers a pretty wide area. So Ed, you were asking the question, can you do kind of multiple approaches, or how do you kind of work together? So what we ended up doing was doing 2 plaques in different areas. And so sometimes you do have to get creative in the approach. And you can see there's 2 different colors on the seeds. So as Matt was talking about earlier, you can change the strength of the seeds in different locations to make sure the tumor is well treated, but also to try and reduce the damage to other structures. And then so we put that in the bottom part. And then we put this over the front surface of the eye, because all of that pigment there on the iris is actually tumor shedding. And you can see that there's no seeds in the bottom, because the area where there's no seeds is overlapping with previous radiation. So sometimes it does require you to get creative and think about how you're going to approach these cases. And then really quickly here, this is a very small lesion that does not have a lot of the high risk characteristics that we've talked about for whether or not something is a nevus or a melanoma. One of the most important things in this situation, and when you were originally a new patient, a lot of times people will ask for previous pictures. And the reason is because just a few months earlier, this is what the lesion looked like. And so even though when I saw this patient the first time, I wasn't that concerned, when you see the previous pictures, you can see that it's grown over a short period of time. And so we talked briefly about biopsy and thinking about this. And so we biopsied this, and it turned out to be a melanoma. And so sometimes biopsy can be very, very helpful in these situations. And for some of our posterior tumors, when we think about plaques, we want to make sure that our plaque, well, in every situation, we want to make sure our plaque is very well positioned. One of the studies that came out from here in the 1990s, when Dr. Harbour was actually a fellow, was talking about the use of ultrasound for positioning of plaques. Is this something that you do? And can you talk a little bit about any of the value, and then we can close off?
Yeah, I think ultrasound localization in the operating room is really helpful. I think it can really help you. I like to check that the plaque is in the right place, with a couple methods if possible. So I think that's a really helpful one. And then you can see is the back edge of the tumor covered well by the plaque? Are the sides looking good? So I think that's really useful. Sometimes also, the eye, sometimes the plaque is kind of made for an ideal eye and not really the actual eye. So like the fit may kind of tilt back, or there may be some fluid or something that between that back edge of the plaque and the eye. And so we can actually measure if there's kind of a larger distance than we, had planned for, and then we can allow for extra time so that it's really gets the full treatment. So I think that's another way that we've kind of used the ultrasound.
Excellent. So yes, this is something that we use regularly, and we do it at the placement, and we also do it at the removal to kind of confirm that there's been no change over time. So in addition to our treatment, we're also really trying to confirm that the radiation positioning is exactly where we wanted it to be. So we will offer up some minutes for questions from the audience if you have any. Please.
First of all, so even though back in the proton side, you guys are complimentary, I think we get more attendance if you put on gloves in the Apion. So you'll fight it out. But I'm curious on the proton side, you've got a proton beam. How are you targeting that so it's really hitting the tumor? What's the effect on all tissue between where it's being injected and where it's planted?
Yeah, so it starts again with the mapping of the eye and tumor geometry that starts actually with a pre-plan where our colleagues will show us the measurements where they plan to place the markers, and our physics team will often suggest moving one here or there to avoid shielding. Sorry. So once we get that plan, we're able to come up with that map, we come up with a preliminary plan, right? But it's ultimately on a simulation day, on a planning day, where we do a bunch of imaging, a bunch of setup, and then a dry run through treatment to ensure that the patient could actually find that gazing light in the right position. So it's, again, this collaborative approach where the ocular oncologist is giving us the geometry we need to create a virtual eye and then plan it in our virtual space. Yeah.
Isolate something.
So it's, the whole localization of the target is based on triangulation. I like to think of these markers as like GPS satellites, right? And so by localizing them in the X-rays, we can pinpoint the location of the target. Now, the question on the entry dose is relevant. And I think one of the major differences between brachytherapy is that we are depositing dose as the beam enters through the anterior part of the eye. So we see these sunburn reactions on the eyelids, blistering, loss of lashes that I think most brachy patients never experience. Right? The trade-off is the less dose to the remainder of the eye. And the reality is it's not a trade-off for most patients. As much as, you'd love to see us fight it out, the reality is for the overwhelming majority of the patients that are coming to us, the referring team does not feel comfortable treating it with a plaque. They think it's suboptimal, and we become a viable alternative to enucleation at that point.
Well, another quick answer to that in terms of the physics of how a proton deposits energy, right? So as it starts entering through tissue, it starts scattering. A proton has a positive charge, so all the atoms around it cause it to scatter, and it starts to lose energy slowly. So that's that entrance dose, but it's really low compared to a photon, right? And what happens is at a certain point, you see that Bragg peak. And that's because the interaction cross section, the probability that that proton is going to interact goes way up when it hits that perfect energy. So the way you control your depth is by controlling the energy of the incident proton.
With after Ed, Tara, you have the mic.
Okay, good point. With brachytherapy, it looked like 16 and 18 millimeters is kind of the relative size of the plaque thing, which is like 3/4 of an inch. Do I get that right? So you guys talking millimeters, yeah. Some of us out here maybe
we have anywhere from 12 or 10 millimeters up to
so half an inch to 3/4 of an inch. How do you get that plaque into the eye to the tumor? How does that work? And how does it stay in place while the treatments going on.
I specifically avoided pictures of this based on the reaction in the phone.
Very carefully. So, it takes surgical skills to put in a plaque, and there's a small incision made around the colored part of the eye, and that skin coupled the conjunctiva is lifted up, and then along the surface of the sclera, we identify where the tumor is, localize it, and then attach the plaque, and it's actually sutured in. And so if you look at the little formations, you'll saw all these little eyelet holes, and those are different places to fix the plaque. And so, one advantage of proton is you don't have to be a good surgeon to get good localization, but for a plaque person, you need a good surgeon.
Well, another thing too, one of the techniques we use for those really small, even posterior lesions, you would think you would want a tiny plaque back there, but it's actually really tough for the surgeon to get that all the way in behind. So we actually take a larger plaque, but we only load the sources at the back. So that way it's easier surgically, but we're still getting the same dose and the same results.
This motion is terrifying.
So you're not a physicist.
Tara, we'll go with you for our last question.
I just have to say, I see things so differently than most human beings. And I feel like, especially being on my own, being my own advocate, for me personally, it is just trusting God sent me to the right doctor and trusting my doctor to have the knowledge to make the right decision for me. And I think that is a gift. I had brachytherapy, and I am so grateful today that my doctor made that decision for me. But for not just y'all, but everyone that's here that aren't the ocular melanoma, I don't call myself a patient, human being, we are so blessed that y'all have the brilliance of the mind and the heart to care enough about saving our lives and giving us more time. And I just want to thank everybody, not just y'all, everybody, because without y'all, we wouldn't be where we are today.
So thank you for those kind words. That will conclude the panel session, and we will have our next speaker come on up. So Dr. Maura Di Nicola from Bascom Palmer is going to talk to us a little bit about what happens after treatment and how do we follow patients. And so this is obviously a question that comes up often: what happens now? And so in addition to being an excellent lecturer, she is the reason why I did not eat with y'all last night, because I did not want to get in trouble for not following my diet. So she is my boss at home and at work, my wife.
Well, thank you for that kind introduction, Dr. Williams. I'm actually not that mean. You can eat whatever you want. So it's a pleasure to be with you all. My name is Maura Di Nicola. As Dr. Williams mentioned, I'm one of the ocular oncologists here. I'm having some serious FOMO about last night. I heard you had a wonderful time. I'm so sorry I couldn't be with you. As Dr. Williams mentioned, we were in Washington, D.C. advocating for ophthalmology and eye surgery. So I stayed a little longer for one of those meetings. Thank you. Thank you. But I am looking forward to spending more time with you this weekend. I want to thank the Melanoma Research Foundation for bringing this amazing event to us, and welcome to Miami and to Bascom Palmer, Sylvester Cancer Center, and University of Miami. So I'm going to be, first of all, I have to be very grateful to the colleagues that preceded me, because they really set the stage for this talk, which is super helpful for me. And so we're going to go over a little bit about what happens after the treatment. And, we had an amazing panel this morning with some of the people here mentioning, you get so focused on your treatment once you get your diagnosis, and then, but you're left with having to live your life after that. And so what happens after that from an eye surveillance standpoint and managing side effects on radiation? These are my disclosures, which are not relevant. I apologize. There is something missing here. I do have research grant from Castle Biosciences as well, but none of this is relevant to this talk. So whenever you come back to see us in clinic, you interact with a lot of these machines. You spend a lot of time in our offices. You end up getting a lot of different testing. And so I want to walk you through that path and why we do that. And so the goals of this talk are going to be to discuss a little bit about what the typical follow-up of a melanoma post-treatment looks like. And for the purposes of this talk, I'm going to be focusing on patients that undergo radiation, so conservative treatment, and I'm going to be discussing eye surveillance alone. In other words, whatever happens for the rest of your body, so your chest scan, your liver scans, I'm not going to talk about that because we're going to have a dedicated talk about that in the afternoon. I also want to review with you some of the regression patterns that we see for melanoma post-radiation. So whenever we're looking inside your eyes and whenever we're taking pictures of your eyes, what are we seeing? And so we're going to be looking at some of those things so that hopefully it's, visually appealing to you as well. And then discuss some of the complications that I'm sure, unfortunately, many of you deal with. And so we went over a great overview of the treatment modalities for uveal melanoma. There's, again, another little warning about a picture that, if you don't want to see, eyes during surgeries, close your eyes for a second. But for the most part, we treat a lot of tumors we're able to treat conservatively with radiation, whether that's proton beam radiotherapy or plaque brachytherapy. And in some cases, we still utilize enucleation, which is a very viable option, as we just discussed. So a question that I, often get asked by some of my patients is, well, doctor, you told me that this radiation treatment that you're performing is going to be very successful, 95 to 98% successful. So why do I have to keep seeing you so often? I like you, but I don't love you. So I don't want to come that often. So the reason is that we want to continuously control the tumor to verify that it's actually responding to treatment and it's actually regressing. And a question that we get a lot is, well, is the radiation just going to make the tumor disappear? Is it going to melt it out? Is it going to cut it out somehow? But the answer really is no. The radiation kills the tumor, and then the tumor progressively shrinks over time. It becomes smaller over time. Think of it as a grape going to a raisin, but that process happens over time. And so my job is to make sure that that process is actually happening with periodic continued follow-up. And I also need to make sure that we monitor you for radiation-induced complication, which, as you've heard, still happen despite our, radiation physicists and radiation oncologists doing such an amazing job trying to reduce the dose to the healthy tissue and maximize the dose to the tumor. The healthy tissues still do get radiation, and so we need to monitor for potential side effects. Our final goal is to number one, make sure to minimize the chance that you get metastatic disease by treating the primary tumor, salvage the globe when possible, and maintain useful vision. And the goals in our minds are always in this order and this order of priority. And so in order to do this, we have to do a complete eye exam, and we get a lot of testing, as I said, which is known as multimodal imaging. So what does multimodal imaging mean? Typically, and this varies a little bit from physician to physician, but I would say that most people that follow tumors will get this set of imaging in most of your visits. The top one that you see there is fundus photography. So we just snap a photo off the back of your eye. This is a treated melanoma, and the yellow dots that you see around that scar are laser marks, and we'll see why we use laser in just a minute. The middle picture is so-called OCT, optical coherence tomography. This is a cut through your retina that allows us to see if there's fluid accumulating in the retina. In other words, if the back of your eye is swelling as a result of radiation. And that's important because that can impact your vision. So those black spaces that you see in there, those black circles, that's the fluid that we're monitoring. And so by giving you those injections that I'm sure some of you and, Allie this morning just kind of mentioned how, she gets repeated injections. That's what we're trying to do. We're trying to get rid of that fluid to improve your vision. And then ultrasound, which, as Dr. Williams mentioned, not super fun to have, but extremely important because that's how we can tell that the tumor is actually shrinking. And so that's how we measure the thickness and the dimensions of the tumor to make sure that it's responding to the treatment. And so the frequency of eye surveillance that we utilize here at Bascom Palmer Eye Institute I tell patients we will become very close friends because unfortunately for you will be seeing a lot of me. But for the first year post-treatment, we see each other every 3 months. Then from year 2 to year 5, every 6 months. And then after year 5, once a year, pretty much for life or for the long term. So let's start with tumor control. So as I said, we need to make sure your tumor is responding to radiation and it's progressively shrinking. So what are some of the characteristics that we're looking at when we do your exams and when we do your pictures? So here you see that there's a large area. So what I'm sure a lot of you are familiar with this, but when I talk to patients, I like to orient them as to what they're looking at. So you're looking at a picture of the back of the eye. The small yellow circle is the optic nerve. The red lines are the blood vessels. You see that at the top of the picture, there is a yellow area with a central brown area. So that central brown area is your tumor scar. So it's still pigmented, it's still brown, but it's scarred down. And all of the yellow that you see around is some of the atrophy. In other words, the loss of the healthy tissue, the retina tissue that was around the tumor and that's been affected by radiation. And so the most important thing that we kind of monitor when we're looking at tumor control is the size. So that's, again, going back to the question that we kind of tackled in the beginning, the tumors tend to not disappear. Most of them will shrink, but they don't disappear completely. About 97% of them decrease in size post-treatment. And so I always like to, really stress that for me, when I'm monitoring patients, a stable or decreased tumor size is considered a good response to treatment. Sometimes patients are a little bit disappointed if they feel like the tumor hasn't gone down in size that much. And so they're getting a little bit worried and they say, doctor, what does that mean? Does that mean the treatment wasn't successful? That's not the case. What I want to see is the tumor not growing, not increasing in size. So stable or decreased dimension is a sign of good response to treatment. And so here you can see, for instance, an example going from January of 2020 to February 2021 of one of our treated patients. Again, you see how much larger and more just elevated the tumor is in the beginning. And over time, that brown area becomes progressively smaller. You get more of the yellow area around it, which again is a sign of the radiation treatment. And when you're looking, so the bottom pictures that you're looking at, those are ultrasounds of the eye. So on your left-hand side is the front of the eye, and on your right-hand side is the back of the eye. So where that little bump is, that lump, that's the tumor. And so you see how it progressively shrinks, becomes smaller over time. So this shrinking occurs mostly in the first 2 years after treatment. So after the first 2 years, then the size of the tumors tend to stabilize. And on average, the tumors go down to 60% of their initial height by 18 to 24 months based on some studies that have been published. It depends a little bit also on how large your tumor is to begin with. If you have a large tumor that's over 8 millimeters in thickness, you will usually have a little bit of a faster initial decrease in thickness, and the tumors will stabilize at about 50% of their initial size. While if you have a smaller tumor, well, there's less to lose, less to shrink. So they're going to decrease in size a little bit slower, and they're going to stabilize at 70% of their initial thickness. And here you see some of the curves that show that. So you see that the curve is steep in the beginning, and on your x-axis you have the time, and so it becomes smaller faster, and then it kind of plateaus. And these two curves on your right-hand side are the difference between larger tumors that lose a little bit more of their volume and smaller tumors. So for instance, this is an example of a relatively small tumor that's regressing nicely. You see that there's scarring, there's decrease in size. But if you look at the two ultrasounds, the bottom one, the lump is definitely smaller, but not that much smaller. It's not pretty, it's not dramatic, but still, again, the tumor is shrinking, the tumor is responding to treatment, and that's expected in smaller tumors. When you have a larger tumor to begin with, so that lump in the upper left corner there is, much more visible. And when you get all the way down to your bottom right photo, then now that lump is definitely smaller there. And again, this is similar concept on fundus photography. So when you're looking at serial photos of the eye, you see that progressively the tumor becomes smaller and you get more atrophy surrounding it. The other thing that we look at when we are doing ultrasound, we look at the characteristics, the reflectivity of the ultrasound. And I'm just going to maybe show you photos because I think it's a little bit easier to understand. Dr. Williams earlier this morning was talking about hollowness when we look at risk factors for bumps in the back of the eye being melanomas. In other words, the color of the bump is darker, is closer to black in the beginning. But as the tumor shrinks, you see that it becomes a little bit whiter over time. So that's another thing that we look at and another sign that the tumor is nicely regressing. A question that comes up sometimes is, do tumors that have a higher metastatic potential, so the ones that are class 2 if you're getting gene expression profile, or monosomy 3 if you're getting chromosomal testing for prognostication, are they more likely to regress faster? Because there was an initial, thought process that, if the tumor was shrinking very fast, that might mean that it was a little bit more aggressive. But studies have been, and here, for instance, you can see an example of that. So this is a tumor. Look at the upper left, that's January of 2017, bottom right, October of 2017. So we're 9 months later. And if you remember, I told you, usually the shrinking occurs between 18 and 24 months. So this is relatively fast. There's a lot less in 9 months. So some different groups have looked at this, and really it doesn't seem to be a matter of size. But again, the most important prognostic information that we can get is through the genetic makeup of the tumor, whether it's through gene expression profile or chromosomal testing. So that's really the most reliable factor that is going to tell you how aggressive that tumor is, much more than how fast it's regressing. It's so here you can see that once in this particular study, they've controlled for baseline tumor height, then the two curves overlap. And so there doesn't seem to be a lot of difference between how class 1 and class 2 regress. The thought process behind that is that it just so happens that there is a tendency for larger tumors to more often be class 2. And so that's probably why we're seeing more shrinking, because I told you that larger tumors shrink faster and more than smaller tumors, and they tend to be more often class 2. That's not always true. There's definitely small tumors that can be class 2, but there is a tendency there, and this could explain what we see. Another thing that we look at is the color of the tumor. As the tumor regresses, it tends to be darker. So the pigmentation post-treatment tends to increase in over half of the cases. Now, that doesn't mean that every increased pigmentation that you see is a sign of regression. Look at these photos here. So on the left, you have the pre-treatment photo. This is actually an amelanotic tumor. So that bump below the optic nerve tends to be a little bit yellowish. Now on the right, you see that it's, nicely treated, regress. Again, some of those yellow spots that you see are laser scars. But look at the center, the very center of that photo, there's a black spot there. That is not in the area where the original tumor was. It's in a different area. It's adjacent to it, close to it, but different area. So that's actually a sign of local recurrence right there. Something else that you might have heard of when you get your diagnosis is that you also might have some fluid underneath your retina or retina detachment. And a lot of patients are concerned about fixing this detachment, but really the way to fix it is to treat the primary tumor, because it is because of the primary tumor that you get that detachment. So the activity that the tumor actively replicating can cause some exudation and some fluid to accumulate underneath the retina. And so as the tumor regresses, that detachment tend to resolve on its own. So the fluid can transiently increase a little bit after radiation as an effect of the inflammation that radiation causes, but then eventually resolve spontaneously in the vast majority of cases, and only some cases will require surgical intervention. This is an example of that. This was a young patient. She was 28 years old when she was diagnosed, treated by plaque. And you can see, so the tumor is the bump that you see on your right. But then you see that in the second picture that I'm showing now, there's like a bump kind of at the bottom too. So that's not actually a tumor, that's a retinal detachment. So it's the retinal that's elevated there, but it's pretty significant. And so you can see again that the tumor is regressing on ultrasound, but those lines that you see coming from the top of the tumor, that's retina, and that's a retinal detachment. And so this patient ended up actually being treated surgically. So her detachment was fixed surgically to maximize her vision. So in certain situations that's needed, but I would say in the vast majority of cases, it's not. Now, moving on to some of the complications of radiotherapy. There are some things that you will notice early after your treatment, and then there are things that you will be dealing with later on, 1-2 years down the road, and that you will probably have to deal for a long time. So sometimes, when patients take off their patch, they'll notice that I tell them it's going to look like you lost a fight. That's totally normal. You're going to have bruising around your eye. You're going to have redness. That's all normal, and it's part of the healing process. Sometimes patient notices that they have what we call ptosis or eyelid droopiness after procedure. That also is something that tends to resolve on its own. So we usually don't fix it surgically. We just give it time to heal. Dr. Dagan earlier mentioned that if you do proton beam, you can have some blistering of the skin, some lash loss. So that's something that you can notice relatively early on. And then he also mentioned double vision, and he's exactly right that we tend to see that more with plaques because in order to surgically place that plaque, we need to manipulate the muscles that are attached to your eye and allow for the movement of the eye in order to put the plaque exactly where we want. However, our group has actually recently published a study where we looked at 375 patients and 321 muscles had to be manipulated, even temporarily disinserted. We always reinsert the muscles at the time of plaque removal, but there was significant manipulation there. And we noticed that about 40% of them noticed postoperative double vision. However, this typically resolved on its own within 6 months. And so again, it is something that you can experience, but more often than not is temporary, and it tends to resolve on its own without the need for surgical treatment. Now, some of the later complications that we're going to go over are listed here. So dry eye syndrome tends to occur a little bit more often with proton beam radiotherapy, but it's definitely possible with plaque brachytherapy. And I'm going to go over the other ones one by one. So let's start with cataract. That's something that a lot of people I've probably heard of. So this is a patient that was treated for iris melanoma with a plaque. You see 3 years post-treatment where the pupil is usually black. You see there it's white is because there's a cataract there. So the lens that's behind the iris is now very opaque and the patient can't really see. This is another example where you see the tumor pre-treatment, again, nicely regressing a year post-treatment, but then 2 years post-treatment, there's that white pupil there that signifies in this specific case a cataract. So this is one of the maybe least concerning side effects for us because we can just remove the cataract surgically. The recommendation that we usually use is to wait for at least a year after treatment, 6 months to a year, just so that we can be convinced that the tumor is regressing and we can safely go in the eye. Dr. Studensky earlier talked about, high dose to the sclera if you're doing a plaque for a particularly thick tumor. So you can get some scleral thinning. So the sclera is the white shell of your eye. If that part of the eye gets very high dose radiation, then it's going to become thinner in that area. And so that those brown spots that you see on your right-hand side are kind of like the regressed tumor protruding from that area that has gotten thinner. And here you see it even more, clearly, and it can happen with proton beam as well. So that was actually a patient after proton beam. And again, the tumor here was very thick, so a lot of radiation being delivered. We heard earlier this morning from Ali and other people about radiation retinopathy and optic neuropathy. So what happens here is that the radiation damages the blood vessels of the retina. And so the retina is not appropriately perfused anymore. It's not getting the food and the oxygen that it needs to function properly. And so you can have a number of complications from that, ranging from microaneurysm, exudates, all the way to bleeding inside the eye. And just to give you an idea of how significant this is, so on your left-hand side, you see a normal retina. And so all those white little lines that you see there, those are all blood vessels. On the right-hand side is a tumor that is an eye that has been treated with radiation for a tumor. You see how much more black you have there and less white lines. Those are all blood vessels that have been lost as a result of radiation. And so that retina is not getting the blood supply that it needs. What determines the development of these complications? There's a number of factors. Number one, the radiation dose, which is correlated to the size of the tumor. The larger the tumor, the larger the amount of radiation to treat it. The location, if it's closer to the macula or the optic nerve, it's more likely to affect them. Some other concurring conditions, such as diabetes or hypertension, or maybe patients that have received chemotherapy before for other reasons, make it more likely to occur. I'm not going to go over this. This is about cytokines, but I know everybody wants to get to lunch, so we're going to skip through this. But what it means is that, the eye really is suffering from the lack of blood vessels, and it's sending signals to the rest of the body to make more blood vessels to be fed, but those blood vessels are not working appropriately. So how do we treat this condition once it develops? We can use laser, we can use injections, and in rare cases, we can do surgery to remove the tumor scar there. We're going to leave that out for now, and we're going to focus on laser. So here you can see, again, the yellow spots are laser treatment. Why is that? Look at the amount of black on that retina. That's all retina that's dead. It's not doing anything. And so we treat it with laser so that that retina doesn't send out those signals that I just mentioned that are telling the body, feed me. Again, if you don't like looking at this, don't look. But in my defense, the needle is not going inside the eye in that picture. It's very close to it, but not quite inside. In any event, these are a number of medications that are available for treatment of radiation complications. They're used for macular degeneration and diabetes as well. The procedure is quick. It's like a 5-minute procedure, not even. It's done in the office, but of course it's, the idea, nobody loves the idea of getting a needle in their eye. We, of course, we numb our patients, we make sure they're comfortable, but this is something that might need to be done a lot over time. And this has been shown, for instance, by this study that looked at patients followed for 10 years. And these patients were receiving injection everywhere from every month to every 3 months. Some of the newer medications last a little bit longer, so you might get away with getting less frequent injections. And it shows that, this is, again, I'm going to skip through the graphs here. What I want to show you is that, for instance, these 2 patients here that were kind of included in this study, they had been receiving continuous injections for 9 years and 7 years respectively, but they were both able to maintain 20/20 vision. That's not always the case. We know that there is a decline in vision over time, regardless of the treatment that we do. But our goal with injections is to try to maximize good vision for you as long as we can. This is a steroid implant. So sometimes you can use steroid injections. Similar process to the one I just showed. There are some potential side effects with steroids. You can develop a cataract. Again, no big deal. We can take it out. Sometimes your pressure can go up, and usually we're able to handle that with drops, but sometimes you might need surgery for that. Again, I'm going to skip through the studies, but several studies have shown that both the first injections that I showed you, the so-called anti-VEGF, vascular endothelial growth factor, work well. The steroids work well as well, with some payoff there. And we can skip through this as well. So if all of this is not done or progresses to the point where all of your retina becomes ischemic, so all of those blood vessels get lost, you might develop something that's called neovascular glaucoma. So abnormal blood vessels start growing in the front part of your eye, and you can develop increased pressure, pain and bleeding inside the eye. So usually your goal is to not get to that stage by doing injections. And there are some strategies to prevent that from happening. And I'm going to quickly go over them. And after that, we're done, I promise. So the first one is surgical customization. We've touched upon this a little bit this morning. Again, laser is one of them. And the same injections that you can do to treat the radiation retinopathy, we sometimes do to try to prevent that from happening. So some centers use silicone oil to attenuate the effects of radiation. That's not done very commonly, I would say, but it works. It's a little bit more invasive. Some other strategies that we are using, as Dr. Studensky mentioned earlier, are using custom shaped plaques, so shapes that really just treat the tumor and try to spare the surrounding tissues, or asymmetric seed loading. You see it on the way to your right. It's a larger plaque, but only the back slots are filled with radioactive seeds. Sometimes we preventively put laser around the tumor because we know that that retina is going to die from the radiation. So we want to make sure that we ablate it, we get rid of it before it even has the chance to send out some of those VEGF. So those vascular endothelial growth factors and cytokines that can cause further complications. So that's the rationale for laser there. And then for the prophylaxis through injections, both steroids have been used, as well as a number of protocols with anti-VEGF. Again, we're not going to go through the details of this, but different protocols are used. For instance, this study looked at doing bevacizumab injections every 4 months for 2 years. This study looked at prospectively injecting patients every 2 months for a total of 12 injections. And in both cases, prophylactic treatment showed better vision. So in other words, patients that were receiving those injections to try to prevent radiation side effects enjoyed better vision than the ones that historically had not received those treatments. So for us, what we do at Bascom Palmer for the most part, we'll give steroid injections at plaque placement, we'll give anti-VEGF at plaque removal. Prophylactic laser depends on the status of the retina, whether there is fluid or not that allows us to do it. And then for the most part, we will do prophylactic anti-VEGF injections, usually every 3 months for the first 2 years in our centers. But as I said, there's wide variability, and there are some considerations based on location, size of the lesion, age of the patient, and so on and so forth. The truth is that Dr. Williams said earlier, a lot of questions that you might ask us, the answer is we don't know. So the question is, which one is better between steroids and anti-VEGF? How long do I have to be doing these injections? When can I stop? Is this for life? And so a lot of these questions are currently unanswered, but thanks to the effort of Dr. Arun Singh, that some of you might know, there is a prospective study called Protocol AL that's now looking at 3 different arms, one receiving the anti-VEGF injections, one receiving the steroids, and one just being observed, so that hopefully we can know how patients respond, who benefits from prophylaxis, from preventative treatment, and how to do it and when to stop. So this is the only slide that's, keeping you from lunch. So we're just going to go through it very quickly. So things to remember. After radiation, the tumor decreases in size but does not disappear, usually over the first 2 years. We need to monitor you closely for recurrence and for radiation-induced complications, and you might need long-term treatment for this radiation complications and sometimes even injections to try to prevent them from happening. I thank you very much for your attention. I'm happy to take any questions now or at lunch, whatever you prefer.
Okay, thank you so much, Dr. DiNicola. And please don't hate me. We're going to do a photo really quick, and then we have lunch set up outside. You are welcome to stay inside with the standing tables or downstairs if you go down to the first floor and kind of out onto the patio space. We have some directors to get you there. We have lovely tables set up outside. So it's like in an enclosed space, so it won't be in direct sunlight. But if everyone could just come to the front here, and then Hazel is going to take a group photo of us, and then you are free for lunch.